2020 PQA Leadership Summit will begin in 5 minutes. The 2020 PQA Leadership Summit will begin in 2 minutes. from the PQA studios in Alexandria, Virginia, and welcome to the 2020 PQA Leadership Summit. I am Lauren Kirk, PQA's Director of Stakeholder Engagement, and it is my honor to welcome you to this year's summit and be your MC throughout the program. I speak for the entire PQA staff in saying that we miss being able to convene with you in person and as we normally would for our Leadership Summit, but we hope you are staying safe and healthy during this time of social distancing, uncertainty, and unresolved elections. The urgent need to address social determinants of health is clearer than ever. The COVID-19 crisis has exacerbated and expanded health disparities. Problems related to food and housing security, transportation, social isolation, and access to care have increased for millions of Americans. And painful spotlights continue to be shined on racial and ethnic disparities in our country. Today, we will explore these issues and leverage our collective wisdom and experience to aggregate social determinants of health interventions that hold promise for improving the quality of medication use, and where pharmacists are best positioned to be providing screening, evaluation, and services. Further, we will engage you as attendees to help us determine the scope and focus of an SDOH resource guide that PQA will develop in 2021. PQA is proud to be your partner in addressing SDOH and improving medication use quality. Speaking of quality partners, we thank our sponsors and supporters that help make the PQA Leadership Summit possible. While they are listed as platinum, gold, silver, and partner sponsors, our gratitude for their support is all the same. These organizations are leaders in quality and committed to supporting programs and initiatives that are aligned with PQA's mission. You'll be hearing more about them and from them throughout the meeting, but you can learn more through the sponsors link on the left side of the screen and platform. Thank you to our sponsors for your sponsorship and support. In order to join us today, you had to log in through a meeting site and platform. I suggest bookmarking this platform's URL and saving your login information. The stage where you are now and through which you will be able to watch the programming will be your home base throughout the day. As many of you know, engagement and collaboration are hallmarks of PQA and our meetings. This will be true of this year's meeting despite the meeting's virtual format. We want you to engage. I encourage you to provide your commentary and ask your questions throughout the day and during the sessions. You do not have to wait for a session to be over or a speaker to solicit your comments. Share those comments and ask those questions in the box below. If you encounter any connectivity issues or technical difficulties, you can find support through the chat box that is on the left side of the lobby page. You can explore other parts of the meeting and the platform through the blue links on the side. Select sponsors to learn more about the organizations that help make the PQA Leadership Summit possible, and check out all of their innovations. Click People to check out who's attending the Leadership Summit with you, and I encourage you to connect and catch up with them using the chat function. And at the end of the day, click Reception to participate in a few fun activities this afternoon, including trivia, mixology, and yoga. So, with everyone settled in, and with all of that out of the way, let's get started. Laura Cranston, PQA's Chief Executive Officer, has led PQA since 2006. And over the course of that time, she has led 29 national PQA meetings. This will be her 30th PQA meeting, and as many of you know, her final meeting as PQA's CEO. So during the next session, Laura will share thoughts on COVID's impact on quality and pharmacy services. She will then lead us in a timely fireside chat on the impact of the crisis on care delivery and the businesses of PQA's membership. So without further ado, Laura, please start us off at the 2020 PQA Leadership Summit.
Thank you, Lauren, for that introduction, and I would love to add my welcome to the 2020 PQA Leadership Summit. I'm pleased that more than 400 individuals from across our member organizations have joined us to discuss the social determinants of health. and participate in an action-focused meeting as PQA looks to develop an SDOH research guide next year. SDOH has been a priority for PQA and for our members for many years. We know that addressing the complex circumstances in which individuals are born and live is important to advancing medication use quality and helping individuals achieve the health outcomes they want and deserve. I can think of no better individual to initiate today's dialogue with than Dr. Jane, who serves as President and CEO of SCAN Group and SCAN Health Plan. A nationally recognized innovator in healthcare, Dr. Jane joined SCAN this past summer, where he is focused on pioneering new ways of improving quality and maintaining affordability for older adults. Dr. Jane has held key positions in the life sciences industry and with HHS, where he served as senior advisor for the Office of the CMS Administrator, part of the founding team at the Centers for Medicare and Medicaid Innovation, and part of the senior leadership at the Office of the National Coordinator for Health Information Technology. Dr. Jane, thank you so much for joining us today. I remember it's been probably 4 or 5 years since I read one of the articles that you authored on social isolation and loneliness. And one of the things that impacted me the most was that you referred to the negative impact of social isolation and loneliness as equating to smoking a pack of cigarettes a day. I also remember that back at a health plan that you were at before SCAN, you hired the nation's first Chief Togetherness Officer. And we had the privilege of meeting that individual, and you gave that person free rein to develop a new program to begin to address loneliness as a disease. So my question for you today to get us started is, what were some of the measures that you used to look at the impact of that program, and what were some of the lessons learned that you've taken with you to SCAN?
Thanks so much, and it's great to be here. I will say the journey on solving loneliness is one that we're, I think, in the first or second inning of really a 9-inning battle. But one of the things that we looked at in the assessment of our togetherness program, led by our Chief Togetherness Officer, was our rate of hospitalizations as well as readmission rates. And what we found is that, individuals who were part of our intervention group ultimately were admitted to the hospital less and were readmitted to the hospital less. And we believe that that was a function, first and foremost, of the fact that having someone in your life, having some connection to someone who cares about you, leads you to care more about yourself and leads you to ultimately take better care of yourself and engage in preventative screenings more, and ultimately manage your chronic diseases better. Because much of our desire and our motivation and our will to live is grounded in our connections with others. And I believe very strongly that the healthcare system needs to do more to create more connections with others.
Here we are in 9 months into this pandemic, and I can speak with an 81-year-old mother, my mom in New York, who is isolated. And we see that across the country. So as a health plan exec, how are you addressing social isolation during the pandemic, and how different does that look compared to pre-COVID?
So we've, I think, redirected many of our staff to really do wellness checks on our members. And one of the, I think, big ahas of doing this work now for a number of years across a few different settings is the realization that, for a variety of reasons, there are many people in this country who don't have anybody. And so the very act of calling in and checking on individuals and making sure that they're doing okay is a very meaningful act. It's something that doesn't happen enough for people. And for many of our seniors in this country, it doesn't happen at all. And so we have a group of seniors who actually we have on staff. They're actually SCAN members who help our patients actually navigate the care system and navigate their health plan, whose efforts have been redirected to do wellness checks on lonely or socially isolated seniors. And Ultimately, I think one of the most amazing things about this problem of loneliness is that it doesn't require us to invent a new medical procedure to solve. It
Right.
doesn't require us to pioneer a new, medicine or a vaccination. It requires us to just direct our will at actually solving the problem. And we have a huge workforce of people who are ready to solve this problem, which is the 300 million Americans in this country,
Yeah.
who, if they decided to connect with each other more, to pick up the phone, to go visit, could actually be part of solving the problem today. And so I think it's a big obligation of people who are in positions of leadership in healthcare to redirect the efforts of their folks just a little bit to make sure that there is this sense of civic spirit and connection to others that can actually really make a big difference.
So did I hear you correctly, though? Did you say you have SCAN members who are doing check-ins with other SCAN members? So are they
We do.
volunteers?
No, they're actually paid employees of Scan Health Plan,
Wow.
and their job is to help folks navigate the Scan system of care, and but as the pandemic struck, we realized that this was an incredible workforce of individuals who would be able to, I think, do important work to check up on some of our
Yeah.
most frail and socially isolated patients.
Wow, that's very impressive. So when we think about the infrastructure that you have at SCAN, SCAN is so unique. SCAN started as a social HMO demo back with CMS, and it was called the Senior Care Action Network, I think in the early 1970s. So you've really been at this for 40 years, maybe a significant jump start on others. How have you built the infrastructure inside of SCAN over that period of time to really coordinate the social needs and the healthcare needs of your members?
So it's a great question, and I want to kind of go back to one word in our founding name, Senior Care Action Network, which is this word action. I think there's so many organizations that talk about social determinants of health, that opine about it, but ultimately this theme of action is so critical to our culture and who we are as an organization that we've actually built a set of processes end to end that really focus on this issue of ensuring that we're asking people about the social determinants of health and then doing everything we can to intervene upon them. Part of our intake forms and intake assessments for our members is a social risk assessment where we ask patients about how hungry they are. We ask them about whether they have challenges accessing medical care because of transportation. We ask them about whether they're lonely or socially isolated. And then we look at the suite of resources that we have, our set of benefits, our care programs, and then we actually match people who have needs to those benefits and to those programs. We also have a wide array of community partner organizations that we actually work with. And so recognizing that we can't solve all of these problems by ourselves, we can't do this alone. And so I think it's that focus and that attention that was part of the founding intent of SCAN when it was founded by 12 angry seniors who were upset about the broken status quo around senior care in this country, that I think continues to guide our program development and our approach to problem solving today.
One of the social determinants of health that's getting increasing attention these days is digital access and digital literacy. So during this pandemic, we've seen so much healthcare services delivered, telehealth, telemedicine. How do you begin to address digital access and digital literacy in the midst of this pandemic?
Yeah, it's a great question, and it's actually leads me to mention a new benefit that Josh Good, our Chief Information Officer, ensured that we introduced to our benefits, for the year 2021, which is actually access to a help desk to help seniors navigate using the tools and technology that are in their lives. Oftentimes we have computers, we have iPads, we've got tablets, we've got phones, but we don't necessarily have the skill or digital literacy, so to speak, that guides us on how to use these tools and technologies. And so one of the filed benefits that we actually filed with CMS was access to this tech help desk that ultimately supports people in using these tools and technology. We got early exposure to the need for this during the pandemic, when we had a number of folks who didn't necessarily have what they needed to access their care virtually. And we have countless stories of members who call and say, I need help setting up an email address for the first time, because you actually need an email address to access many online digital tools and technologies for your health. And so we're helping people with things as simple as how do you set up an email address. So it's been particularly gratifying, and it's been a great to be part of finding solutions to serve the people that we serve.
That is great. I didn't realize you would have to file for CMS for a service to offer a service like that, but that's very cool, very innovative. Wow. Hey, I want to switch topics for a minute. And when I went out before COVID in January to visit Scan Health, one of the things that was so impressive to me was the way you utilize community health workers. And that's part of the infrastructure that you've built to address SDOH factors. How has that worked for you? How do you use community health workers differently than maybe another healthcare professional? Can you talk a little bit about that?
Yeah, I mean, I think we sometimes, overbuild programs, and we require too many certifications and too many degrees for, to ultimately accomplish what I call radical common sense, which is this idea that, people who care can actually solve problems for people who need solutions. And, at Scan, we were recognizing that you don't always need a nurse. You don't always need a doctor. Sometimes what you need is a neighbor who actually cares about you. And so we have, one of our implementations of community health workers is something called Connecting Provider to Home, which is, where we actually send community health workers into medical office appointments with patients who sometimes don't necessarily understand the instructions that they are being given, don't necessarily, have the health literacy that they need to manage through a health situation. And they need someone who can actually be the fabric between that medical office appointment and the instructions that they're given in that medical office appointment, and then making the changes that they actually make in their lives. And we've found that it can be an incredibly important kind of intervention to offer patients with complex illnesses and multiple problems. The added navigation of a community health worker can be the difference between adherence, which is, I know, a big theme here, for all of us at PQA, and non-adherence. And so, I think the challenge is, of course, making sure that we're intervening upon the right patients, because you can create a lot of waste in the healthcare system when you provide solutions to people who don't need them. And so a lot of the work that we have to do, I think, as a healthcare system more broadly, or as a country, is figuring out where the resources are best applied, because we don't have unlimited resources.
Right. I could not agree more with that statement. I want to switch gears for a minute. You've also written a lot about the intersection of quality, underserved populations, and Medicare. And I just want to take for a minute, you recently tweeted, and I am not on Twitter all too often, but I actually saw this one. It says, "We need to acknowledge the pernicious effect rating systems such as the Medicare star ratings have on disincentivizing healthcare organizations from serving underserved communities." You said it's one of the biggest challenges to health equity in an increasingly pay-for-performance world. So I wanted to ask you, if you would, to go backwards. You spent significant time here inside the Beltway at CMS and HHS and ONC. If you were, now that you have these lived experiences as a CEO of 2 health plans, what would you go back and tell your peers in the administration in CMS and HHS about how these plans are maybe not aligning incentives appropriately? What could we do here inside the Beltway?
Yeah, it's one of the reasons I believe that government needs a constant influx of people who've actually operated in the real world, and I think it's all about being aware of the unintended consequences of the systems that we create. I think everyone has the best of intentions. Everyone who worked in the quality measurement world has the best of intentions. But if you create systems that disproportionately reward performance without necessarily acknowledging the challenges of achieving that performance in a particular population, you end up pushing organizations, nudging them in the direction of actually serving people who are a little bit easier to serve. So, here at Scan and previously at CareMore, our performance is governed by the Medicare Stars system, and the differences, in payment between achieving 4 and 4.5 stars or 3.5 and 4 stars are remarkable. It's between $50 and $100 per member per month. Over a year, that's more than $1,000 per member if you're talking about a swing between 3.5 stars and 4.5 stars. So the rewards are extraordinary. Now, if it's easier for me to achieve those rewards in a simpler to serve population, of course, the rational operators would ultimately focus their efforts on growing in communities where it's easier to achieve those rewards. And so I think the challenge we have to kind of overcome is ensuring that we're not creating disincentives to serve communities and patients and populations that may not be as easy to reach. People who maybe for whom English is a second language, communities where the provider networks aren't necessarily quite as sophisticated. And so I think some of these ratings and ranking systems have this incredible effect of creating disproportionate incentives to serve easier to serve populations. So I think we have to take a hard look at that. And organizations like PQA, through their government relations and lobbying efforts, I think need to take a leadership role in nudging federal regulators and policymakers to consider these unintended consequences, even as they're building programs to raise the bar for everyone.
I don't disagree, and well noted. I'd love to have a CEO roundtable of health plan execs come to Washington or participate in a Zoom call and share this feedback directly. I'm sure that they would be interested in hearing it. We certainly we certainly try to carry that message whenever and wherever we can. I totally hear you on that one. But speaking of tough populations to manage, I have to address the homelessness situation because you're living it every day in cities like LA and San Francisco, and I'm from New York City, so whenever I go back home I see it. And I recently read an article, it was back in March in JAMA, and it talked about whether or not CMS should create a homeless special needs plan. And I'm just wondering, your thoughts as a CEO of a California health plan where you walk out on the streets and you see it every day. How can we meet the needs of this population that is so unique?
Thanks. Yeah, I wrote that article in collaboration with John Backus, who leads LA Care, as well as Jim O'Connell, who leads Boston Healthcare for the Homeless. And I think all of us believe that one of the challenges to how we think about homelessness is that we're not necessarily thinking about a total cost of care perspective. Many seniors, many homeless individuals or individuals experiencing homelessness actually are Medicare eligible. And many of them incur very significant healthcare costs because their primary means of access to the healthcare system is the emergency room. And access to behavioral health and addiction treatment, which are two big problems in the homeless population, are quite challenging. And so, I fundamentally believe, I think all three of us fundamentally believe, that one of the biggest opportunities we have to attack the homelessness problem at its roots, which is oftentimes a healthcare root, whether it's medical conditions that predispose you to homelessness or medical conditions that arise because you are homeless, is actually working to build a better healthcare delivery model. And so we're actively reorienting many of our efforts here at SCAN to ensure that homeless individuals who could benefit from a program such as Medicare Advantage have a program and a plan that's very closely tailored to serve and solve their needs. And it's something I know that the SNP Alliance is actively engaged in advocating for. And I've been fortunate to share this concept with Seema Verma, the administrator at CMS, as well as Brad Smith, the head of CMMI. And I'm very optimistic that I think we can align the energies around this to actually create a solution for one of society's most significant and frankly most embarrassing problems. We're in 2020 where we have unprecedented wealth in this country, and yet we have individuals who are lying on the streets and who are uncared for. And I find it morally reprehensible and something that's totally unacceptable and something that we have to build, I think, real policy solutions to solve.
A quick question as we close out our conversation. PQA is the Pharmacy Quality Alliance, and we think a lot about the role that pharmacists can play as we emerge from this pandemic and as we look to address these social determinants of health. So when we think about medication access, adherence, appropriate use of medications, what do you envision as the role that pharmacists can play to address some of the social determinants that impede access to medications?
Ultimately, what I can say is I believe that the scope of practice for pharmacists needs to be expanded. And I think that this pandemic is a great opportunity for us to test that. My own experiences with pharmacists at CareMore was that they are some of the most thoughtful, most organized, most engaged professionals in the care of patients. And I'm very biased because some of my best friends are pharmacists, people like Lloyd Myers, Rena Acharya at CVS Health. And so, when I think about them and their capabilities, I believe that they should be doing more. And I think that, we should be thinking about what part of the care journey could be owned by pharmacists. And I think things like chronic disease management, I think ordering and administering some of our preventative care measures, vaccinations, all of that can be, well managed and well oriented through pharmacist collaboration with other healthcare professionals. I think a lot of what the nurse practitioner field has undertaken on behalf of patients could in fact also be absorbed by the pharmacy profession. And so I would say we should be looking carefully at what pharmacists might be able to do in a new healthcare system.
Well, we would welcome that conversation at any time with Scan Health, because we believe too that pharmacists are uniquely positioned out there in the community and can be doing so much more, and that's really what they want to do. And during this pandemic, we've practiced at the top of our license, and we've been given all these emergency use orders that have come down from on high from HHS. And really our goal is to make sure that some of the things that we can now do during this pandemic, we'll be able to do once this pandemic is over.
Absolutely. I mean, we have an extraordinary pharmacy department led by Sharon Jawar, and I think we're always looking for new ways to think about how pharmacists could influence and impact the care of patients. And I think one of the things we're looking at right now is actually pharmacists playing a far greater role in care coordination going forward. So stay tuned for more from SCAN on this topic, because it's something that we're very passionate about here.
Yeah. Well, thank you. And I want to thank you for sharing those insights today, and looking forward to working with you and Sharon Jawar. We really appreciate having her serve on our board of directors. It's very helpful for the overall strategic direction of our organization. But wishing you the best, and looking forward to seeing how you can continue to impact your colleagues back here inside the Beltway at CMS and HHS as we engage in these really difficult conversations. So thanks for being with us today.
Thanks so much. It's been a real honor.
Today's meeting would not be possible without the generous support of our sponsors. Let's hear a word from some of them now before we continue with today's summit.
When we get back to work, let's work to make sure it's not business as usual.
When these rooms are full, let's make room at the table.
When we open up,
let's be more open.
Let's decide that the way it was
not the way it should be.
Let's make the opportunities and the money equal.
Let's all be a part of the decisions.
Let's recognize that women have the same rights as men.
Let's stand together.
Let's make things better.
Let's change.
Let's change.
Let's change.
Let's give 50% of the population 50% of the voice.
We are in this together.
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 We are passionate about finding solutions
to the most vexing challenges
in healthcare today.
We know there's power in the data.
And we find those solutions together.
Together.
So patients can get the medications they need
at a cost they can afford.
We believe
in a healthier tomorrow.
I am
AMCP.
I am AMCP.
I am AMCP.
We are AMCP.
Welcome back to the 2020 PQA Leadership Summit. I'm Richard Schmitz, PQA's Senior Director of Communications. Our next two speakers will address the types of SDOH interventions that can improve the quality of medication use and where pharmacists are best positioned to provide screening, evaluation, and services. We'll start with a pharmacist perspective and how pharmacies are integrating SDOH into their workflows. Then, we'll hear why SDOH is important for health payers and how pharmacies are being leveraged in their SDOH programs. First up is Jill Reagan. Jill is a Director of Relationship Management at LexisNexis Risk Solutions. Our second speaker is Lillian Dahey. Lillian is Humana's Associate Vice President for Patient Safety and Pharmacy Stars. After their presentations, both will join us live to answer your questions. Please share your thoughts on the issues and send us your questions in the box below. Let's hear from them now.
Thank you for joining today's session on promising practices to address social determinants of health through pharmacist-provided care. My name's Jill Reagan. I am a registered pharmacist, and I have experience in working in retail pharmacy for over 25 years. Not only did I provide diabetes-related services when I was a pharmacist working behind the counter, but I also was able to provide pharmacy-related services outside of the pharmacy, not only by appointment, but through other vehicles. In my previous role as a pharmacy district manager, I know the importance of not only filling prescriptions efficiently and profitably while focusing on patient care, giving immunizations and screenings, and most importantly, ensuring patient safety. Today, we're tasked with prioritizing areas of focus where we as pharmacists can do more and improve the quality of medication adherence. Socio-determinants of health has been around for many years and is an increasingly growing buzz in healthcare. A pharmacist has the most recent access and interaction with patients, and there are many things that we can do to not only impact patient adherence, but also to improve their overall health outcomes. Prior to COVID-19, we already were aware that chronic conditions were driving majority of our healthcare costs. According to fightingchronicdisease.org, in 2020, 48.8% of the American population will have at least one chronic medical condition. As outlined on the right-hand side of this slide, some of the chronic conditions that you are already aware of, you probably already have programs in place to address. It's in the middle of the slide where we have a sense of urgency. Chronic conditions are the cause of 7 out of 10 deaths in the United States. 81% of hospital admissions and 91% of prescriptions filled are due to chronic medical conditions. We also know that 76% of all physician visits are a result of patients with chronic conditions. Now, these people are the ones we need to focus on because they can't postpone their health, and we need to have some type of an effect to improve not only their overall health outcomes, but their medication adherence. So we as pharmacists play a critical role. Studies have shown that by April of this year, office visits were down at least 60% compared to last year. And even now, they're down 30% compared to last year. Americans are just avoiding physicians' offices, clinics, and hospitals. And we also know that telehealth visits are on the rise. The people with chronic medical conditions simply know that this is negatively impacting their health. We also know that COVID-19 has not only impacted patients' socioeconomic status, but people are now concerned with their financial stability, their unemployment opportunities, as well as losing their health insurance. So that's the bad news. The good news is that in May of this year, the Alliance for Community Health Plans did a poll and determined that the pandemic has not greatly impacted in-person visits to the pharmacy. In fact, over 90% of respondents that had received new medication did so from their local pharmacy. Additionally, 90% of Americans do live within 5 miles of a pharmacy, and patients with chronic medical conditions have 35 or more visits in a given year to the pharmacy. So this means that pharmacists and pharmacies are poised to serve the critical needs that we have in the US, with being the trusted and safe center for patients avoiding physicians' offices and for us to identify and improve their medication adherence. Predictions can be highly useful on medication adherence and motivation. So for adherence measures, we're really trying to predict not just who might not get their prescriptions filled, but also to gain insight into why they won't get them filled. The understanding of why is critical if we're going to align our services to improve our patients' adherence rates. In order to mitigate risk associated with patients not coming in or being out of compliance, social determinants of health can be matched to social and community services. So take, for instance, if a pharmacy has a patient who's socially isolated and lacking transportation, the pharmacy can then target that particular individual for possible medication delivery, or maybe a ride share, either to come in and pick up their prescriptions or possibly to get them to their physician's appointments. We know that Lyft offers rides for Medicaid eligible patients in 23 states in order to get them either to the pharmacy or to their physician's visits. But we also know that Uber and Lyft have partnered with NimbleRx for prescription delivery. So these are services that, as pharmacists, once we identify them, we're able to refer and get patients into these services in order for them to be more medication adherent. Another study shows that 68% of patients reported that they had at least one socioeconomic challenge that would impact their medication adherence. These might be things like financial insecurity, food and housing insecurity, where they're trying to make decisions on whether they can pay their bills and feed their families versus getting their medications filled. These also might be things such as health literacy. So pharmacists, for patients who have been identified as having issues with paying for their medications, pharmacists are very well poised to recommend drug discount programs where applicable. There also might be able to provide promotion of financial services for patients who might need more of the supplemental security income Medicaid versus the temporary assistance for needy family Medicaid. So it would be an opportunity for a pharmacist to recommend these types of financial services when identified. Another area might be patients who have a barrier with health literacy. An opportunity might be to embed a barcode or something in a monograph so that the patient can then download a video and be able to understand a little bit better how to take their medication and what their medication might be for. Predictive modeling, data, and analytics can really help pharmacists and organizations identify the types of barriers that a patient might be facing with their medication adherence. And they're very poised today as pharmacists to be able to identify these opportunities. But let's face it, the challenge today in pharmacy is that resources need to be allocated to performing these analytics and putting that information right in front of the pharmacist in real time, so that the barriers can be addressed at the time that the pharmacist is filling or dispensing that prescription. We know that pharmacists are frontline workers. We appreciate them, and so do their patients. But at the same time, they're very busy. And so there need to be additional resources that are available to them to help identify these barriers. Let's take a look at how predictive scoring and modeling based on socio-determinants of health can be utilized in the pharmacy workflow to help improve medication adherence. These types of scores and alerts can be provided right in the pharmacist workflow as they're filling a prescription. If we take a look at this slide, we have 4 patients. On the surface, they all look the same, and as far as medication adherence, we might not know anything different about each individual. They're all male, they're all approximately 55 years old, and they've been prescribed medication to treat the same medical condition. Now, studies have shown that 20 to 30% of prescriptions are never filled, and 50% of medications are for chronic diseases that are not taken as prescribed. So it's really important to understand not only these statistics, but for the pharmacist to understand of these 4 individuals, who's most likely to not be adherent. Who can we do something to prevent their non-adherence? But more importantly, why potentially are they non-adherent? When we implement predictive scoring in the pharmacy management system, the medication adherence score can be presented right there for the pharmacist. So if we take a look at these 4 individuals and what information we know about their social determinants of health, this would be better able to assist a pharmacist into identifying what opportunities and what resources they might be best to align with that particular individual. So let's take a look at Jack. Jack on the left-hand side of our screen, he's about 20% likely to be to adhere to his medications. Some of the barriers that Jack faces are the fact that he's seen a decrease in his financial income over the past year. He's also has minimum banking experience. So by providing this information to a pharmacist might be able to recommend some financial assistance for Jack. They might also be able to recommend some drug discount programs that Jack might be able to take advantage of. Because let's face it, with a reduced income, Jack is struggling to find the opportunity to pay his medical bills, his utility bills, as well as his medication. If we take a look at Manny and Will, they're also a little bit more less likely to be to adhere to their medications. Manny lives in a high crime neighborhood. He's also been involved recently in a car accident. So a pharmacist, knowing this information about Manny, might be able to recommend transportation. So maybe a rideshare program, so Manny could come in to pick up his medications, or might align Manny with some type of medication delivery program. If we take a look at Will has some different struggles. Now, Will is a little bit more likely than Jack or Manny to adhere to his medication protocol, but he doesn't live near a relative. His nearest relative lives over 100 miles away. So studies have shown that patients who have a relative or an associate that lives more than 25 miles away are less likely to adhere to their medications. So Will is also socially isolated. So we might want to recommend some support groups. The pharmacist might need to check in more frequently with Will. And we might also recommend medication delivery or possibly rideshare programs so Will can come in and pick up his medications if he has no one available to bring him to the pharmacy. And then finally, we have Chen. Now, Chen is 90% likely. So on the surface, these 4 individuals do look like they would be adhere to their medications, but at the same time, if you get deeper under the surface, you'll see that there's other things going on that might preclude them from being adherent to their medications. Utilizing social determinants of health insights, we as pharmacists and PBMs can better partner with our community resources, or in fact, build in-house programs that can address these types of needs that we see with various patients. So to wrap things up, pharmacists really can play an active role in community health efforts. We can allocate resources and time to those who need our support the most. We could be educating patients and counseling patients, but also helping to solve for transportation, financial issues, or other challenges that we've identified or have been identified by social determinants of health. Predictive analytics really can provide guidance on those fronts for each individual patient. At the corporate level or plan level, you can use social determinants of health insights to help segment your patient population into groups based on risk. identifying frequency and density of health barriers within those segments. You can then make decisions about programming and resource allocations across maybe your regions, your districts, and even at the local store level, so that you can address varying needs by patient to help better understand the risk within your population. With an understanding of each individual's social determinants of health, the local pharmacist really can help at-risk patients become more adherent with their medications. It's not just about asking questions and providing counseling information on particular medications, but it's digging deeper to identify social influencers that might be affecting that particular patient's adherence. So, for example, asking questions of a patient about transportation issues that keep them from coming into the pharmacy might improve the ability to refer patients to various resources. As a pharmacist, then we have a more holistic view of a patient that can not just their medical or claims history, that can really help us focus a little bit more on improving the quality and health for each and every patient. We all know that medication adherence really does cost the US about $100 to $400 billion a year. So this is a lot of potential savings in other medical related costs that we can have an impact on, not to mention the potential revenue in our pharmacies as patients continue to fill and receive medications that they're prescribed. We know that there's other services outside those that I've mentioned, such as 24-hour live chats, customized daily medication packaging, wellness programs. There's a large variety. You can have self-training kiosks in your pharmacy. You can have self-tracking devices on activity levels, depending on what the patient's needs are, to meet their needs not only with medication adherence, but overall services to improve their health. So in conclusion, as the pharmacy industry continues to shift to more value-based care contracts, social determinants of health can really provide that much-needed view of what challenges each and every patients are facing in order to achieve their medication adherence and overall optimal health. Using these social determinants of health can create community resource programs, allocate resources across your pharmacies or your regions, and help build a more loyal customer base, because we know that patients not only appreciate their health plan, but more importantly, appreciate their pharmacist for giving them that personalized care. I hope I've given you a lot to think about. I look forward to your questions, and I thank you for your time today.
Good morning. My name is Lillian Ndehi, and I lead the Patient Safety and Pharmacy Stars organization at Humana. And we are responsible for the development of pharmacy programs with the goal of improving clinical quality and outcomes. And this includes medication safety and adherence. I also oversee Humana's quality network, where we are focused on developing innovative clinical programs in partnership with pharmacists that showcases the importance of holistic management of our members and improving health outcomes. This is why I'm honestly excited to be here today to talk to you about the opportunities for pharmacists to address social determinants of health, factors that are known to have negative health impacts and are critical to address in order to improve medication use and health outcomes. So today I'll be talking to you about social determinants of health impacts, insights, strategies for pharmacist-provided care, and I'll also be reviewing 2 pharmacist-provided care pilots that we've either completed or are currently underway. So we know that the reasons why patients do not take the medications as prescribed is complicated, and it's usually entangled with unmet social needs, such as food insecurity or housing instability. I thought it would be important to start with a human care success story that reminds us the role we play in delivering quality experience in partnership with our clinicians as our way to improve health outcomes and advance the care of our members. One of our pharmacists identified a 70-year-old Medicare member who was non-adherent to her chronic medications and was from a low-income household. And when they talked to her, she expressed high levels of stress, had financial strain, and had poor housing quality that needed repairs. The pharmacist referred the member to a local home repair service that provides services for elderly and disabled low-income homeowners. The member was very grateful for both the screening and the referral. And this is what she said. I wasn't prepared for anybody to call me because I was never able to be successful. So I was going in around in circles, wondering what to do and how to do. I appreciate you calling. I was thinking I'd have to give up my house, but I didn't know what else to do. My house is my independence. You sure made my day good. You gave me hope, something I didn't know still existed. I don't know about you, but when I read this, it again really emphasized the role that we can play in really partnering with our members to help treat those social needs so that they can be able to improve their medication use. So that to me is such a great story, again, that tells us what we can do for our role for the social determinants of health. So why are organizations such as PQA, Humana, and other organizations putting a lot of focus on social determinants of health? So we know that 60% of health is impacted by behavioral, environmental, and social conditions. The 2018 Consumer Perspective Report revealed that 68% of the Americans surveyed identified having challenges in at least one social determinant of health risk category. So I'll let that sink in. 68%. I found that very, very interesting. We also know that health-related social needs are associated with worse health outcomes and have an impact on medication access, adherence, as well as health outcomes. What this data shows is that barriers outside of the clinical setting, like healthy food, can negatively impact a patient's health, and addressing these needs in patients is critical to improving in an individual's overall health. So one of the things that we knew was going to be extremely important was that it was critical that we understood our members' comprehensive social needs so that we could identify areas of actionable opportunities so as to improve their health outcomes. And what we ended up doing was that we conducted a multi-channel survey from October 2019 through February 2020, and we used a nationally representative sample of Medicare Advantage members, as well as Florida Medicaid beneficiaries. There are a few things that I'd like to highlight on this slide. The most prevalent social determinants of health are financial strain, food insecurity, and social isolation or loneliness. And this was consistent for both Medicare and Medicaid members. What I'd also like to point out is that every social determinant of health listed here can have an impact on medication access or adherence. So for example, if a patient has financial strain, they may not fill their prescription or they may choose to skip doses. If they have food insecurity, they have the option of choosing to buy food or buying medications. Members that are found to be lonely or socially isolated usually have lower adherence. And if they do not have transportation, they may be unable to pick up their prescription at the pharmacy or go to their physician to get a prescription. Housing insecurity or utility issues also may impact a patient's ability to properly store the medications. For example, those medications that need to be refrigerated. I think this highlights the importance as pharmacists to address these needs so that we can be able to improve medication access as well as health outcomes. So when we think about how we can best leverage pharmacists in addressing social determinants of health with our members, there's several things to take into consideration in order for us to have meaningful and impactful solutions. So I'd like to start by discussing the social determinants of healthcare continuum, which really shows the different steps we need to really think through to engage our members. This is usually initiated by identifying patients that would benefit from an outreach, and this could be identified through predictive analytics or risk mapping. The next step would be to outreach the patient so as to perform the social determinant of health screening, collect the data, as well as identify the resource that is available in the patient's community. The pharmacist would then provide the resource referral based on the identified social need. So, for example, if a member says they had food insecurity, that may be an opportunity to refer them to a food pantry. And of course, the goal here would be for the member to receive treatment for the identified social need, which will allow them to better take their medications. This would then be followed up by asking or following up with the patient to address the outcomes of the resource referral. So, for example, you'd ask them, did they use the service? Or was it easy to contact the resource? We also recommend measuring the impact of the intervention. So, a great example would be, did the service help meet the patient's needs? Did the resources that you referred them to have enough capacity? Were there any improvements in outcomes, whether it's medication adherence improvement or greater healthy days? Also, we know that these factors are changing constantly, so we would recommend that one should consider evaluating these factors frequently. We realize that in order for us to have a sustainable model for pharmacist-provided care, certain factors are needed. And one would be social determinant of health data infrastructure, which would include having a standardized format for collecting data, as well as having technology that would allow use and the exchange of data. So, for example, if you collect data that a member is food insecurity, being able to immediately communicate that to the payer would be something that would be extremely beneficial, or even communicating that to that patient's physician. Something else that's also critical, because again, population health is local, is that community engagement is important. And this includes the business leaders, the local government, or nonprofit organizations. And these are the ones that either support or manage the community resources needed to treat the social needs. We also need to deliver evidence-based scalable solutions. And right now, how we're doing that is through performing pilots to measure impacts of interventions on outcomes. So some of the things that we're doing would be including measuring medication adherence lifts, greater healthy days, seeing if the members or patients have a lower A1C, or if they have lower inpatient admissions, among others. What we're also doing is partnering with key partners to have this social determinants of health discussion or continuum as part of their workflow. I think the other important factor that we've realized just based on our pilots and discussions is the importance of pharmacist preparedness. We realize that this is generally not part of the traditional practice of discussing medications. What we can tell you is that we have seen that some pharmacists make meaningful impact to help members address the social determinants of health. And we would really like to see greater receptivity across pharmacies so that we can continue to impact these factors that, as we know or we've discussed, have an impact on medication access. They have an impact on medication adherence. They have an impact on health outcomes, things that I know we're interested in influencing and having a positive impact. So, as mentioned in my introduction, one of the areas that I focus on is really looking for those areas where pharmacists can be able to provide holistic management so that we can continue to demonstrate our value in improving member health. And one key area is how we can be able to work with our members and work with our communities in addressing social determinants of health. So we have implemented some pilots, and I'll be discussing two today that I'm extremely excited about because I truly believe it shows the value that we bring in helping our patients. The first pilot was implemented to understand how we could tackle the social needs through the community pharmacy. And we targeted Medicare members that were non-adherent to certain chronic conditions, including COPD, depression, hypertension, diabetes, among other conditions. And the pharmacist provided or performed social determinant of health screenings using a 9-question survey that was based on validated screening tool that has been published by CMS. This is something that is actually publicly available. And what we found through this pilot, and that was 2 months following the intervention, was that the most prevalent social determinants of health were loneliness or isolation, food insecurity, as well as transportation. We also observed a statistically significant reduction in medical spend in all cohorts. And then we also noticed that there was impact that varied by conditions. So for example, we saw that there was a higher prevalence of social determinants of health for members that had COPD and depression. And we also saw positive medication adherence lists for COPD, depression, and osteoporosis, but we did not necessarily see that with other conditions. Something else that was also extremely important to us was making sure that we got feedback from our pharmacists that would allow us to make enhancements in future pilots. Because again, our goal is to really develop those evidence-based scalable solutions so we can be able to work with our patients to improve their health and well-being. And we got some really, really good feedback. So one was really talking about how we could offer best practices, including the best way to engage the patient to complete the screening. Because again, these are not discussions that generally pharmacists have with their patients at the retail counter. And they also wanted to know how they could use motivational interviewing to get the patients to open up about a sensitive topic. So if you think about it, some of the questions that we're asking our patients are asking about if they're lonely or if they are concerned about running out of food. And, some people are able to be open, but I will tell you that those patients that may not be as comfortable talking about that. So it's really critical to be able to utilize tools like motivational interviewing to be able to have that open, candid discussion with our patients. There's also feedback about providing client-specific resources, including a list of community resources that the pharmacist could refer their patients to. There's actually also a strong desire for pharmacists to receive education on how they could find these community resources on their own and refer the patients to those resources. The one thing that got me excited is that through this pilot, we were able to demonstrate to Humana, to the enterprise, and to others that pharmacists can be leveraged to have effective social determinant of health conversations with our patients. We always use opportunities to learn, to become better. And we use a lot of information that we gathered from that pilot to develop our second pilot with our telephonic pharmacists today. And I'd like to note that this pilot is still underway, but we have definitely gotten some good preliminary information, including the human success story I shared with you at the beginning of this presentation. And in this particular pilot, we targeted members that were non-adherent or they were at risk of non-adherence to certain chronic conditions, to certain chronic medications, and that is specifically for diabetes, hypertension, or hyperlipidemia. And the interventions we were interested in measuring this time around was both the social determinant of health screening, as well as the delivery of an adherence intervention. And what I mean by that is having a very targeted discussion about the members' adherence to the medications and understanding what barriers may lead to non-adherence or is causing non-adherence. And we were able to make a couple of enhancements that I would like to review here. So one of the things that we're very mindful was making sure that this time around we provided a proactive pharmacist network resource and training prior to launch so the pharmacists could really feel confident that they had the information to discuss with their patients as well as refer them to the necessary community resources. Also, the social determinants of health screening is being completed. And for every social need that is being identified, our pharmacists or the pharmacists are providing referrals through those that are identified through screenings. Pharmacists are also following up anywhere from 4 to 6 weeks after the initial discussion to discuss the use of the resources, as well as address any medication adherence barriers. And we believe this is a valuable piece because the patients will be able to connect the social determinant of health that they may be experiencing and how that may be interfering with their medication use, their quality of life, and their health and well-being in general. Also, the pharmacists are documenting the screening, the referrals that are provided, as well as any information they're gathering through that follow-up outreach as part of the member journey through the continuum. And the reason why this is extremely important to us is that this data will tell us what resources are most utilized, what resources are most referred, and how members engaged and are satisfied with these resources. We hope to learn a plethora of information, but I'll highlight a few that we definitely have on our radar. We want to better understand what social determinant of health prevalence that we are seeing in this particular population that may be resulting in non-adherence, and are we seeing overlap with other prevalence that we've seen in previous studies. We also want to understand member engagement, or who are likely to engage, why are they likely to engage, as well as the most referred resources, as well as the most utilized resources by our patients. We're also interested in understanding the trends in medication adherence, if we see any savings from a medical and pharmacy cost perspective, as well as impacts in healthcare utilization. So this could be things like ER or inpatient admissions. We're also gathering feedback from the members as well as pharmacists to understand what's going well, as well as what additional enhancements we can implement to make sure that these services and programs continue to be successful. So in conclusion, we believe that pharmacists have a unique value proposition in addressing social determinants of health, as they know their patients and available resources in their communities. They can be able to help the peers bridge the gap by making those connections and truly understanding the social needs as well as the community resources that are really making an impact on our patients' health. We also believe that this will positively impact medication use and health outcomes of our patients and will allow us to scale evidence-based solutions and will continue to showcase the value that pharmacists bring in managing the whole person's health. Thank you, and I will open it up for questions.
All right, thank you, Lillian, for that presentation. And Jill, thank you for kicking us off. To our audience, we're now taking your questions. I have an iPad in my hand here. Your questions are being fed directly to me, so I'll read them as we go. So I want to start off with a question for both of you. We're in the midst of this COVID pandemic, and I want to get your opinion on what SDOH factors have been escalated or elevated during this pandemic that need to be addressed with priority. Lillian, do you want to go first with that?
Absolutely. So the social determinants of health we've seen are an increase in the rate of social isolation and loneliness, and we are observing this due to the distancing protocols. Something else that we have observed is an increase in food insecurity, and that is expected because patients are not able to either access the food or they're unable to afford the food. Something else that was interesting observation is also the transportation barriers, and this were in situations where the patients needed to go to their physicians for a medical appointment to potentially get a new prescription or a change in prescription. So I'd say, those are really the three trends that we saw with the COVID pandemic.
With COVID and people, not understanding where there might be at risk with their income, there's a lot of people affected, either having to go on unemployment or work in a service industry and don't know where that next paycheck is going to come from. So there's a lot of financial insecurities in addition with COVID that we're seeing, as well as what Lillian had mentioned. Obviously, if you don't know where your income is going to come from, the concern with, food instabilities as well as social isolation continues to increase.
All right. All right, well, thank you for those insights. We have a number of questions that are specific to the presentations you've provided us, and I want to tackle a couple of those now. And so, Jill, I'll start with a question first for you. You had mentioned in your presentation the variable of 25 miles and beyond, and that seems very interesting and quite logical. Is that a screening question, and how are those data collected?
Well, actually, I don't work with the screening type questions, but the data that we have at our access to shows that patients who live more than 25 miles from a relative would be considered socially isolated and less likely to adhere to their medications. Someone checking in on them frequently would improve their medication adherence. So I think that would be something that we might want to consider in our screenings, is to ask the question of, do you have a relative that lives nearby? Do you have a friend or an associate that you have in close contact with? Because that will help us understand if they have a support system that can really help them.
Great, thank you. Lily, it sounds like a lot of the work that Humana is doing in this space is with in-house, phone-based pharmacists. Does Humana have any plans to expand the pilot opportunity to include community pharmacies?
Yeah, absolutely. Actually, as a matter of fact, the first pilot that I talked about was specifically utilizing community pharmacies. We're able to partner with a vendor where the pharmacist had actually access to data for those members that were eligible for the social determinants of health screenings, as well as referring them to the appropriate community resources.
All right. Lillian, I'm going to put this next question to you as well, and I'm going to let you go first with this because of your title. You have Pharmacy Stars in your title at Humana. And there's a question of, could star ratings criteria also incorporate the effort toward addressing SUH rather than only the outcome? What are your thoughts on that?
Honestly, I think that is a great question. We have data that shows things like age, gender, low-income subsidies, disabilities inadvertently impact our members, whether it's from a medication adherence perspective or even medication safety perspective. So when we have the ability and CMS or the organizations incentivize us to continue evaluating as well as customizing our interventions to more holistically and more appropriately address those differences in social needs, I think that will be extremely critical, because again, that is something we are consistently seeing in our data, and we see
Excellent. Jill, anything to add on the potential of the star ratings program to account for SUH, not only outcomes, but also the work that goes into identifying and addressing problems?
No, Lillian put it very well. The more information that we have about our patients, individualized to that specific person and the barriers, that is only going to improve our ability to patient adherence, but understand what barriers they have to improving their overall health. So information is valuable. We could analyze and be paralyzed by information, but having that information right at our fingertips really does help improve not only stars, but just the overall health of a patient. That's what we're here for.
I agree.
So I want to ask a question related to data. Good data, consistent data is critical to everything we do in healthcare, delivery of services, quality improvement. Do you believe that it is feasible and desirable to move towards a standardized SDOH assessment? And is that feasible given the many different ways that individuals touch the healthcare system? Jill, do you want to start with that one?
Sure, absolutely. You know, data is valuable, right? So the more data we have, the more value we can provide a patient. The key here, though, is that self-reported data. Let's face it, some patients don't want, as Lillian mentioned, don't want to share that sensitive information, and a survey, they may not want to be very honest about us or about their situations, depending on the types of questions. So the more data, a survey definitely will give us that information, and maybe partnering, as Lillian mentioned, with a third-party vendor to be able to provide broader insights can augment not only the surveys that we can implement in our community pharmacies or in our plans, but bringing some additional insights would definitely help in identifying some of the barriers. You know, we had an experience with a patient who did report on a survey and gave a home address. And when we looked at what that home address was, it was a vacant plot of land. So you want to make sure that the patient is providing honest information in those scenarios, but oftentimes I think only 4% of patients or members might return surveys. So trying to understand exactly what the key questions that we would want in our surveys is critical.
Lillian, thoughts?
Yeah, I would echo that there is a desirability to standardize a screening tool. And, you know, when I think about that, I think it allows us, one, to standardize our approach with our patients. And I think it also provides us an ability to be able to easily aggregate the data as well as analyze the data, because we realize that there's an importance to really be able to measure the impact. So I'll give you an example. So at Humana, for example, we took the opportunity to test a few screening tools, and then we ended up settling for the accountable health
has to be doing. So it's the question about the sustainable business model around SUH screening and care. Lillian, do you want to go first with this one?
Absolutely. So what has us excited, what has me excited, is we truly believe that pharmacists play such a critical role in holistic management. And we have numerous opportunities, including determinants of health, to really showcase how we can maximize. And that is why we are choosing to engage in this pilot, where we're able to incentivize the pharmacists for them to screen the social determinants of health, for them to refer, and we're using that information to be able to showcase the value so we can continue investing and the pharmacist. So that's why, as I mentioned early in the presentation, having the pharmacist being prepared, having the pharmacist engaging, having the pharmacist really taking the time to follow up and close those gaps will allow us to have the evidence, the value to continue integrating the pharmacist in addressing this critical area.
Jill, your thoughts on the sustainable business model for addressing SDOH via pharmacies and pharmacists?
Well, absolutely. I think as what Lillian said, there is the pharmacist putting the tools in front of them and having them available to them. But we all know that in many community pharmacies, you have pharmacists who are very busy with just filling and dispensing, right? So do you separate the roles of pharmacists who provide these services, who do these surveys and complete the referrals, versus having just a pharmacist who fills and dispenses medications, things like that. So I think the sustainability is the wave of pharmacy, because we do provide value. This is the proof that we do provide the value and should be considered as providers of healthcare. And not just a pharmacist filling prescriptions. But again, as Lillian mentioned, you have to have the tools. You don't want to boil the ocean on your services either. And again, think about your patient population. What are the low-hanging fruit? What is the service that you can start initiating and identify that it's shown value and has improved medication adherence and other health outcomes? Take transportation, for example. Maybe that's something that you target. Providing delivery services, those types of things. But it's definitely a sustainable model. It's just identifying in your specific pharmacy or in your organization how you want to implement and what you need to implement and what tools need to be available to your pharmacists.
That's great. All right, I have a couple more questions that are specific to the presentations. Lillian, for the pilot that you described, how long were the pharmacist or provider appointments, and how was that work integrated into the overall pharmacy workflow?
So the initial pilot that we completed was for approximately 3 months. And the idea here was that we sent clinical alerts or social determinants of health opportunities through our vendor. And we know that pharmacists generally will review for opportunities, whether it's medication adherence, whether it's statin gaps, whether it's other opportunities that they need to address with their members. So again, it's part of the workflow that pharmacists are already doing today to address medication-related needs and gaps. What we thought about here is adding that non-medical component as part of something for them to review and address with their members. Because again, the opportunities here are thinking through how we have those discussions as part of whole person health.
And Lillian, related to those specific reviews and interventions, were you able to track kind of the approximate time that a pharmacist or a pharmacy personnel staff person might spend on an individual, opportunity?
That is not something that we tracked, no.
Okay. Well, team-based care is obviously something that everyone is interested in and focused on. And this is a question that came in during the opening conversation with Laura Cranston and Dr. Jane. But it was about how can manufacturers, the life sciences companies, collaborate with health plans and others to incorporate SDOH into value-based care deliveries. So I know both of you are not, in the life sciences, companies, but from your perspectives, how do you see life sciences partnering with organizations like yours and with pharmacies to expand services in this way? Jill, do you want to take that one first?
Yeah, I'll try. So I think life sciences and pharmaceutical companies might be able to partner with, for example, I'm thinking in those scenarios where we have patients with health literacy concerns, providing tools for the particular medications or even the medical condition that would help a patient better understand maybe a video or some type of link, partnering with pharmacists to be able to provide those types of tools if that's an identified barrier. We know that pharmaceutical companies in some cases do provide some type of discount programs. So for patients who have financial concerns, that might be another opportunity to assist patients with the cost of their medications and partnering with pharmacies on those areas. Screenings might be another one, depending on like diabetes, A1C type tests or screenings. Partnering with pharmacists there are some areas I can think of that we might be able to leverage that team and that collaboration.
Yeah, I'd like to, echo what Jill said. I think there are a variety of opportunities. One could be specifically targeted to close the gaps of social needs. So we know that cost, for example, is something that impacts medication adherence, and there are, patient assistance programs that may be available, or foundations that may be available to offer assistance to this patients. I think other things to really think about is when we think about the social determinants of health, and when you think about their treatments, a lot of this are related to our communities having the resources, the staff, the funding to be able to have the food that they need or offer transportation. And so there are opportunities there to really think about how do we fund this community organizations? How do we partner with nonprofit organizations? How do we partner with local leaders that they have the funds that they need to be able to meet the needs of their community? I think something else that we found that will be critical for us to invest in, and Humana is partnering with a variety of organizations, is how do we create or how do we invest in a technology or a platform that allows for the social workers, the pharmacists, the community workers to be able to do the screening, be able to figure out what resources are available for that particular member's needs, to be able to send that referral to the nonprofit organization, and to be able to consistently track the utilization. I think that is one opportunity that, quite frankly, would require companies to invest, for us to really be extremely thoughtful on creating those tools that promote efficiencies or even increasing capacity. So I think that's something else that the life sciences or pharmaceutical companies should or could consider.
It makes a lot of sense to provide, any frontline workers with those types of tools. Related to that, there was a question about training that came in. What type of training do pharmacists need to be more involved in this work? And Lillian, for the Humana program, are there specific, trainings that you guys have implemented that are kind of helping pharmacists be better capable for doing this work?
Yeah, absolutely. I think there are several components when we think about training for the pharmacist. I'd say one of the biggest component is, why are social determinants of health important? I don't know about you, but I went to pharmacy school. I don't remember, reviewing that information. And I think it's critical, right? I mean, 60% of health is impacted by social, environmental, and business needs. So I think it's important to be able to showcase why it's important for us to address the social determinants of health. I think the other component is, how do we engage our patients to have those frank discussions? How do we make them comfortable? So I talked about motivational interviewing, because again, these are sensitive topics. And that will be critical in order for us to have the right data to determine prevalence as well as referrals. I think that the component that we've realized is important is being able to accurately or better refer to the patients to the appropriate community resources that will be helpful for the patients. And I want to emphasize a lot of this are local based or are unique to the community. So what may work for Louisiana may not necessarily work for Florida. So it's extremely important to be able to educate them on what resources are available to their patients within that community.
All right.
That's it. Those are some of the things that we have taken into consideration. Oh, you're welcome.
All right. Well, thank you, Lane. We have time for one last question. And PQA is focused on medication use quality, adherence, safety, access. I want to ask you, if you have limited resources, if you have limited opportunity, what SDOH issues would you start with first to address SDOH and improve medication use quality? Jill, I'll let you go first with this one.
Sure. I think Lillian said it in her presentation. You need to focus on the financial assistance that patients, especially now with COVID, are really faced with, right? That could be, an area of focus. That could address food concerns, as well as transportation concerns. So those are the areas I would really start with. You probably couldn't do all three, maybe you could, but I would really start with the ones that have the highest barriers, especially in the pandemic that we're faced with. So even outside, the concerns have just grown. So I would start there.
Okay. Lillian?
Yeah, sure. And to add to what Jill said, I mean, we've evaluated a lot of social determinants of health, and as shown in my presentation, some of the most prevalent are food insecurity and social isolation and loneliness. And Humana has chosen to focus on this too because they have an impact on overall healthy days. And as I discussed earlier, we know that this has an impact on members' ability either to choose to access the medication or even to adhere to the medication. We know that members will prioritize food over medicine. We know that when members have a behavioral conditions, they will not engage in taking their medication. So, if we were to select two, I'd say food insecurity and social isolation and loneliness.
Great. All right, well, we are at the end of our time for this session. Jill, Lillian, I want to thank you so much for being a part of the PQA Leadership Summit. You've given us a lot to think about as we try and think about where to focus our energy in addressing SDOH. And I also want to thank our audience for the questions that you have submitted. For questions that we weren't able to get to today, we'll try to share those with our speakers so that you can get answers to what you have asked. So I want to add my thanks to our sponsors for this meeting. Our work would not be possible without you. So let's take a moment now and hear from two more sponsors.
Caring for the world one person at a time inspires and unites the people of Johnson & Johnson. J&J embraces innovation, bringing ideas, products, and services to life to advance the health and well-being of people around the world. J&J believes in collaboration, and that has led to breakthrough after breakthrough, from medical miracles that have changed lives to the simple consumer products that make every day a little better. Over 125,000 employees in 60 countries are united in a common mission: to help people everywhere live longer, healthier, happier lives. PerformRx is an NCQA and URAC accredited pharmacy benefits manager located in Philadelphia, Pennsylvania. Formed in 1999, PerformRx maintains a clinical culture providing cost-effective therapies and extensive evidence-based programs at an optimal cost to its clients. PerformRx's best-in-class pharmacy benefit management services include formulary development, drug therapy management, and rebate management. Perform Specialty is PerformRx's wholly owned and integrated specialty pharmacy. Markets serviced by PerformRx include Medicaid, Medicare, commercial, and employer group. To learn more about PerformRx, Perform Specialty, and the services we provide, please visit our website at performrx.com. Strong foundation for us as we continue our important work this afternoon. But before we get there, we're going to be breaking for about 30 minutes. And during that break, I encourage you to explore our meeting sponsors and connect with each other using the functions in the blue bar to the left of the screen. I had a minute to glance in here, and we see you online. Lauren Dixon, we see you. Alicia DeStefano, Michelle Johansson. All of y'all are there. Let's get connected just as you would at a live PQA meeting. And so with this online format and these unfamiliar times of COVID, PQA wanted to make sure there were a few familiar elements during our Leadership Summit. And many of you know this would be the time that we dismiss you to a break where you can snack and network and rehydrate. So during this break, all of our attendees will receive a $5 gift card to Starbucks where you can refuel. These gift cards will be delivered via email during the break or shortly after the meeting's conclusion, so be on the lookout. This break and this gift are sponsored by Involve Pharmacy Solutions. So let's hear a message from them as we head into our break.
Involve Pharmacy Solutions provides total drug management that includes pharmacy benefit and integrated specialty pharmacy solutions. When it comes to pharmacy benefits, one size does not fit all. We customize our solutions to fit our clients' unique needs. As a top PBM, we have the clinical expertise to provide tailored programs that reduce costs while improving care. Contact us to learn about our innovative PBM services. includes pharmacy benefit and integrated specialty pharmacy solutions. When it comes to pharmacy benefits, one size does not fit all. We customize our solutions to fit our clients' unique needs. As a top PBM, we have the clinical expertise to provide tailored programs that reduce costs while improving care. Contact us to learn about our innovative PBM services.
meeting will resume in 5 minutes. Our meeting will resume in 2 minutes.
Involve Pharmacy Solutions provides total drug management that includes pharmacy benefit and integrated specialty pharmacy solutions. When it comes to pharmacy benefits, one size does not fit all. We customize our solutions to fit our clients' unique needs. As a top PBM, we have the clinical expertise to provide tailored programs that reduce costs while improving care. Contact us to learn about our innovative PBM services.
Welcome back to the 2020 PQA Leadership Summit. I hope you are returning refreshed and refueled, and thanks again to our break sponsor, Involve Pharmacy Solutions. A few audience members have asked when the recordings of our Leadership Summit will be available. Those will be made available by next Tuesday, and all registrants will receive an email with a link to those recordings. Continuing on with our programming is another member of the PQA team. Patrick Campbell is PQA's Senior Director of Research. Patrick will explain PQA's interest in SDOH, describe our projects underway, and level set us all on SDOH factors that we will rank later this afternoon. Patrick?
Hello, everyone. It's my pleasure to join you today to discuss PQA's focus on social determinants of health, which I will refer to as SDOH moving forward, and highlight some of our SDOH-related work. My name is Patrick Campbell, PQA's Senior Director of Research. So why are social determinants of health a focus for PQA as an organization focused on medication use quality? Well, the answer is quite simple. In addition to the traditional domains of healthcare, addressing the complex circumstances in which individuals are born and live is important to advancing medication use quality and helping individuals achieve positive health outcomes. Additionally, understanding the complex interplay between SDOH and health outcomes through foundational public health and health services research can inform initiatives that aim to improve medication access and quality. As many of you know, PQA has developed a number of medication adherence quality measures. But adherence only captures a small fraction of the medication use picture, as it only tells us whether a person was able to successfully pick up a medication. We do not know anything about the upstream encounters that may affect a person's ability to gain access to those medications. Several healthcare access and utilization conceptual frameworks have been created and used for decades to identify and target gaps in care. However, none of the frameworks focused exclusively on medication access and its associated barriers. So, in partnership with the National Pharmaceutical Council, PQA set out to develop that framework. We convened a multi-stakeholder roundtable of experts from across the healthcare continuum, including health plans, community pharmacies, government agencies, professional organizations, research groups, as well as representatives from the patient community, so that they can help develop a framework specific to medication access. The group leveraged 2 scoping reviews and an environmental scan to identify medication access barriers, interventions impacting medication access, and existing medication access quality measures. The group also made consensus-based recommendations for future work, which is available in the Access to Care report, which is available on our website. The roundtable developed the Medication Access Patient Journey conceptual framework. It is designed to provide a more holistic view of medication access. As seen here on the slide, the framework includes 7 nodes that represent the various stages a patient encounters while gaining access to medications. It starts with perceived need, goes through help seeking, encounters with prescribers, receiving prescriptions and having them processed by the pharmacy, dispensing and counseling of those medications, and finally adherence to those therapies. Its cyclic nature conveys that barriers and challenges occurring upstream of adherence can have significant impacts on medication access. The Access to Care report also contains predominant barriers patients might face, including health system, provider, and patient-level SDOH variables that are mapped at each node. As you can see, barriers like cost, health literacy, transportation, and insurance coverage can influence multiple access nodes. And these barriers represent opportunities for targeted intervention. It should be noted, these barriers are not an exhaustive list, but they do help identify key barriers that should be considered when designing interventions to improve access. Since the release of the Access to Care report, PQA and the National Pharmaceutical Council released a request for proposals for research projects that address access barriers to medications. 2 projects were selected, and we are excited to collaborate with the University of Rhode Island to evaluate the impact of patient out-of-pocket costs for oral anti-cancer medications on medication adherence, and work with researchers at the Johns Hopkins University to assess the impact of a real-time prescription benefit tool on access to medications. We are actively working on these projects and look forward to sharing findings during our 2021 annual meeting. A project that PQA recently completed, in collaboration with Liberty Software and VUCA Health, found that prescription medication educational videos increased medication access. For this study, we focused on primary medication non-adherence, also known as PMN. PMN is a subset of medication non-adherence and focuses on the initiation of new prescriptions. PMN occurs when a new prescription is prescribed, but the patient is not able to pick it up within an acceptable timeframe or provided with a therapeutic alternative. For this study, we compared pharmacy PMN rates across a group of pharmacies that offer medication educational videos to a group of pharmacies that did not provide the service. The videos were sent via text message or email to patients when the pharmacy received a prescription electronically by a prescriber. The medication videos represent a health literacy conscious intervention to improve medication knowledge by providing patients with the most important information regarding the newly prescribed therapies. Topics include potential side effects, indications, proper administration, as well as expected benefits of the treatment. Videos average 2 minutes in length and have a 5th to 6th grade reading level. This study highlights the importance and the impact of targeted interventions that can overcome specific barriers to medication access. Like the PMN study, there are other initiatives that have been completed or are underway to overcome access barriers and address SDOH to improve healthcare for all Americans. And pharmacists are serving as a critical member of the healthcare team to accomplish this goal, since pharmacists can see the patient's struggles first. As one of the most accessible healthcare providers in the US, pharmacists know their patients. However, access to pharmacies may be different across different communities. In the absence of formal pharmacy access designations, there is heterogeneity in pharmacy access definitions in the literature. We know that influential spatial factors like time travel, distance to a pharmacy, or pharmacy to population ratios are important. But there's also non-spatial factors like race, income, insurance coverage, and as well as transportation access that must be considered when defining pharmacy accessibility. Although these variables have been identified, they have not been validated. So, in partnership with the University of Arizona, PQA is developing a conceptual model defining pharmacy accessibility and describing levels of access in metropolitan areas with significant history of racial segregation. These findings can help support future population health initiatives to improve pharmacy access for all Americans. Another area of focus for PQA relates to the landscape of SDOH data availability. We know data plays a critical role in the business and delivery of healthcare, especially within value-based frameworks where reimbursements are tied to health outcomes. Yet, we know very little about how these social determinants data are collected, shared, and used. And understanding the structural and organizational mechanisms that healthcare stakeholders leverage, as well as the challenges that they face in collecting and using SDOH data, will advance our collective ability to meaningfully capture these data and address barriers so all people can have high-quality care. To shed light on this important area, PQA has partnered with the Texas Center for Health Outcomes Research and Education to administer a multi-stakeholder survey to answer these important questions. These findings will help inform future directions for pilots and demonstration projects, highlighting best practices, and developing standardized tools and resources for pharmacists to collaborate with other members of the healthcare team to effectively address SDOH. So it may not come as a surprise, but SDOH is a PQA strategic initiative moving into 2021. One of our goals is to create a resource guide that will detail the SDOH interventions most likely to improve medication use quality and where pharmacists are best positioned to provide screening, referrals, and interventions. This summit is where that work on that guide begins. We have identified 7 factors or action items that are likely to be featured in an initial resource guide. And we want your collective wisdom and experiences to inform how they are prioritized. These 7 SDOH issues were described in the brief pre-read document that we distributed to all summit attendees. I will review them here in advance of the polling exercise you will participate in at 2 p.m. today. As we go, share your comments and your questions in the box on the screen. We'll evaluate some of those comments in the next session, and we'll take all of your input into account as we move forward developing this resource guide. So let's review those 7 factors now. Screening for SDOH identifies and documents patients' unmet social needs, which affect medication access, adherence, and outcomes. As trusted and accessible providers embedded in the community, pharmacists are pivotal partners for screening and follow-on SDOH services. The cost of medications is a barrier to obtaining needed medicines for many Americans. However, there are many ways to address the direct out-of-pocket medication costs and help patients access low-cost or even free medications, including co-payment assistance and formulary modifications. Patients come from diverse cultural backgrounds that may influence their understanding of health and illness, interactions with healthcare providers and institutions, and engagement with treatment recommendations. Pharmacists can impact care through reduction in cultural and health literacy barriers, through needs assessments, education, and health coaching. Individuals without reliable access to affordable and nutritious foods are more likely to be non-adherent to medications. Pharmacists can help patients access food assistance programs and recommend pharmacotherapeutic options where the effect is not dependent on foods. Decent, safe, and affordable housing is central to good health, effective care, and positive health outcomes. Pharmacists can play a role in screening for housing issues and referring at-risk and vulnerable individuals to housing support services. Loneliness or social isolation is one of the most common SDOH issues reported by patients. The high frequency of pharmacy patient encounters, including telehealth expansions, represents an opportunity to better identify loneliness, improve social support networks, and provide resource referrals. Limited physical mobility and the inability to get to a pharmacy to obtain prescriptions is a major challenge that many patients face. Affordable, reliable public transportation, rideshare partnerships, and other non-emergency medical transportation options can help address these barriers that stand between patients and their needed medications. These are some of the issues that we're starting with. We look forward to your feedback, including whether there are other major SDOH factors that we should be prioritizing at this time. After a quick word from our sponsors, Lauren Kirk, our Director of Stakeholder Engagement, will chat with the panel of PQA members about these factors, and we'll share some of the comments that you've submitted today. Thank you again for being a part of PQA Leadership Summit.
Thank you, Patrick, for that overview of SDOH barriers and opportunities. We thank the sponsors and supporters that help make the PQA Leadership Summit possible. These organizations are leaders in quality and committed to supporting programs and initiatives aligned with PQA's mission. Let's hear from two of them now.
It's about the humans. These humans, those humans, Groovin and Golden. It's about getting more than health insurance and a partner who listens and acts. Humana calls it human care. It's talking to a doctor from your couch or helping you find a cheaper prescription before you ask. It's helping you fix the rugs so you don't fall and keeping you social, online or off. It's getting to know you so you can be your healthiest. That's our superpower. That's human care from Humana.
Aspen RX Health is a first-of-its-kind mobile-based technology company with the largest community of clinical pharmacists in the nation. They intelligently match their pharmacists with health plan members based on often overlooked social and clinical determinants, including language, cultural relevance, geography, and areas of clinical specialization. This level of intricate matching allows their clinical pharmacy services to drive member experience, clinical outcomes, and sets the foundation for longitudinal provider and patient relationships. Their areas of service include chronic disease state management, quality performance programs, medication adherence, medication therapy management, and more. A hallmark of PQA meetings is the active engagement of members. While we are not able to engage and be together as we have before, we're preserving that opportunity for you to share your perspective and amplify your voice. The next session here will be two commingled conversations. The first, driven by you. Share your thoughts about the SDOH interventions that hold promise for improving medication use quality and where pharmacist-provided care can have the greatest impact. Which factors do you think should be prioritized? Share your thoughts through the question and comment box. PQA staff will be elevating some of your comments and sharing them with the entire audience. The second conversation, the panel of Leadership Summit attendees and PQA members, this panel will serve as a reactor panel to this morning's programming and give us, as attendees, additional perspectives to consider when scoring a set of SDOH factors and issues. Each panelist has unique experience, perspectives, and expertise in addressing SDOH. We are thrilled to have each of them join us for this conversation today. So let's get started with our panel. Welcome to all of our panelists. We have three folks here that I want to go ahead and introduce and really get started with our conversation. So Maureen Hennessy is coming from Precision for Value as the Senior Vice President, Director of Value Transformation. Libby Hoy is from PFCC Partners and is a patient family advisor. And then Helen Corliss joins us from Health First, and she is the Assistant Vice President of Clinical Strategies for Pharmacy. Welcome, everyone. I want to dive right in. So, Maureen, let's start with you, Maureen. what should manufacturers do to develop or evolve their strategy as it relates to addressing social determinants of health? What's the manufacturer's role here in addressing SDOH?
Thanks, Lauren. It's great to be here with everybody today. So I think that manufacturers have some opportunities to engage with multiple stakeholders. We're talking about health plans, systems, patient advocacy groups, to address the social determinants of health and to address some of the stressors that have been exacerbated by COVID-19. And in doing so, they can expand value. They can also help close some of the disparity gaps that are glaring. They can also really help support our efforts to attain the quadruple aim. We did a survey earlier this year of health plans and health systems to identify what were some areas where they would be willing to and even interested or even currently collaborating with pharmaceutical manufacturers in the social determinants of health area. And three of the areas that really popped up, not surprisingly, access to medications, health literacy was also very prominent, as was also food insufficiency. And when you do a deeper dive and you take a look at population health management, which really is hand in glove with social determinants of health, we saw that there was a lot of interest on the part of health systems and health plans in collaborating with pharmaceutical manufacturers on helping patient members to manage side effects, helping promote medication adherence, and also patient engagement kinds of initiatives, whether those be person-to-person or whether they be more virtual in nature. And the other thing that I think was really striking was they said that they were quite willing and very interested, in fact, many of them, in collaborating on crisis management initiatives during COVID-19 and also on other crises, because they see this, unfortunately, as perhaps the tip of the iceberg of some of what we're going to be dealing with for a while. And so with that in mind, what I would really suggest, Lauren, is that manufacturers, in a very systematic, very comprehensive way, really do a review of their strategic and tactical initiatives to address social determinants of health from the very beginning, whether you're talking clinical trials all the way through launch and patient assistance programs on an ongoing basis. And I can give you some ideas in terms of that. So, for example, when you think about clinical trials, many pharmaceutical manufacturers will collaborate with patient advocacy groups. And those patient advocacy groups, particularly now, can be such advocates in terms of helping you as a pharmaceutical manufacturer to think through where are the social determinants of health particularly adversely impacting your patients or your potential customers. And then what they can do is strategize to address those social determinants or social risk factors, and even serve as ambassadors for you in some ways in addressing some of those issues. Likewise, I would also say that it becomes really important to take at how you're interacting and using your patient assistance programs for patients, particularly now when people feel so which is one of the hallmarks of this pandemic. It was also referenced this morning by some of our speakers, by Laura and Dr. Jane. And so from that perspective, we can do things like we can better promote our patient assistance programs. There was some research done last year or so on that something like 2/3 of patients, particularly ones with conditions or complex conditions like cancer, would be very interested in participating and connecting with patient support services offered by manufacturers. Yet, only about 20% of the survey respondents said that they even knew about these programs. And so working back, pharma can work back with key stakeholders, whether it be health plans, whether it be patient advocates, your own patient assistance services, to promote these programs, and then further to really take a close look right now at how your patient assistance teams are addressing social determinants of health, not only in the area of access to medications, which is vital, but also are there other that they can potentially link patients up with services for to help address the needs that they may have that are obstacles to health. We'll talk a little bit more later, if you like, about the issue of the culture of science and messaging and who are your optimal messengers, if you like.
Absolutely. I want to, you've mentioned patient a number of times, and obviously when we're considering SDOH, we're certainly focused on the patient. And I want to bring Libby Hoy in here. As a patient family advisor here, Libby, what's top of mind for those patients? You've heard Maureen mention there are plenty of patient assistance programs out there, but how are we getting these connected? How do we get these connected to address SDOH?
Great question, Lauren, and thank you so much for having me on this panel. I think the fact that PQA has invited a patient and family caregiver to participate in this panel is just such evidence of the determination of this community to really address social determinants of health. And funny, as Maureen was talking, I grabbed my pen to make a note to connect with Maureen to have her speak to our patient and family advisory network so that we do promote those services. I was just thinking last week as I went to my local pharmacist, and the pharmacy tech actually said, you know what, I think there's a program for this, and I hadn't even really researched it. So I think we do have some more work to do there together. And I think together is the point I want to drive home really loud and clear. And you mentioned that I come to this work as a patient family advisor, as someone who's raised 3 sons living with mitochondrial dysfunction and survives stage 4 salivary gland cancer myself. And it's that perspective, I think, that we want to continue to partner with organizations like PQA and all of its members to authentically bring that voice forward in partnership to co-design the solutions that we all need. I think I wanted to share that early in the pandemic, through our work with Los Angeles County Department of Health Services, we've been engaged with them for about 2 years now to authentically engage the residents of LA County into the health system, into its quality improvement initiative specifically. And so early on, we were tapped to get together with our community here in Los Angeles County and find out, what are people worried about most and what's top of mind. And across the board, it was, how do I get my medication? What am I going to do if I can't get to the pharmacy or the pharmacy's not open? And so I think we're very, very much in good alignment that this is a critical nature. So I'm going to reference the PFA network a couple of times during my comments, so I want to make sure everyone understands. As part of our organization, we support the PFA network, which is about 620 people like myself who are using their lived experiences in the healthcare system to influence it, be it with research partners, quality improvement programs, health systems themselves, and newer into the mix are payers and measure developers. So through that, and early on to combat some of the isolation that's been mentioned several times today, we stood up Friday morning coffee chats. So anybody who was feeling isolated in our community could just log in on Friday morning. It was just a chance to connect. And we really did that because we were concerned about some of our senior population, in particular in our rural populations, feeling that sense of isolation. But what has gone on since March, all the way through, is we've gotten this incredible glimpse into how communities across the country are experiencing the pandemic, and again, how they're experiencing access to care issues, including medication and staying on their typical protocols. So I'm just, again, really happy to think about PQA's commitment that as we think about access and medical programs, that we're doing so in the context of people's lives. So one reflection I wanted to share as I listened to Dr. Jane this morning speak about the health desk that SCAN is setting up to meet the needs of the senior population who may have limited virtual access or virtual competency. And so I think those kinds of efforts are really key to continuing the conversation, continuing the relationship with people who are trying to navigate this pandemic and this healthcare system. We hear from members of the PFA network, again, across the country, that people are using their influence and their connections across the community. So that's a point I wanted to kind of think about together. How can we really connect with our community members and allow them to be the connectors across communities? I think the community-based pharmacist, again, has, when I think of mine, it's essential piece of my team, right? And so how can those community pharmacists be catalysts for those and connecting points along with your patients and your family members that you're serving? So what we've heard in terms of the virtual divide is a couple of encouraging pieces, I think, and then also, of course, some areas that we need to address. Some of the encouraging areas are the quality of virtual visits and the ease of virtual visits once we kind of get folks over the hump of getting on that first and transitioning into a virtual world. We hear about convenience. We hear about cost savings. We had one mom who took her daughter for their annual, usually took her daughter for their annual neurology check-in, and that usually consisted of a 2-hour drive each way and considerable stress for her daughter who experiences disabilities. And in the virtual visit, she felt like was a better quality visit because her daughter was in her home setting and her baseline was more accurate than it was. So there's all these kind of wonderfully maybe non-intended benefits to the virtual world that I really want to keep focus on, because I think patients and families are really appreciating that aspect of it, even while we acknowledge the challenges of some communities to access. So what we've heard, particularly in our rural communities, is unique partnerships in the communities. For instance, one community in Iowa partnered with their education system, their school district, to sort of piggyback onto all of the wire that was getting laid for the education system, and then how they could make those connections. So they were working together with some of those unique partnerships. And so I think, again, as we think about what the community pharmacist and the patients and families have in common is that relationship base and ability to be connectors across their communities. So I really appreciate the tremendous efforts to address social determinants of health presented here today. I think clearly PQA members understand the connection of social determinants of health and a patient's ability to access medication. As a patient-driven organization, we're expanding our own thinking about how to establish equitable health outcomes. I will say that we've been on a learning journey ourselves over the last 6 months, both with our PFA network members, particularly the PFA members that are represent the Black and African American community. And what we've realized is that although inclusivity has always been a core value of ours, and we always included anyone who came to our door, what we've recognized is we don't have enough doors and they're not in the right places. So we really need to expand how we move forward with creating more opportunities in the communities. We've really come to believe that communities have the best knowledge of the issues, right? The local solutions are those that are going to get us the furthest. So they have the best knowledge of the issues. They also have the skill set to solve them. What they don't have are the resources. So how do we think about how we sort of democratize the resources across communities, engage community-based organizations, engage partners that we haven't traditionally done to really get to identifying the priorities, local priorities for social determinants of health. I think our goal is to standardize an individualized approach to care, including access to medications.
Excellent.
I also want to mention the impact of patient-family advisors. So again, those of us using our lived experience to influence the healthcare system. We've largely been sidelined during the COVID and pandemic response. And of course, in the initial days of the response, we enacted our incident command centers and had all of those protocols in place. And that really quickly sidelined our patient family advisory councils in our health systems, in our research teams, even in our quality improvement work. And so I think it's important to continue to create those connections, and Maureen referenced those as well. Connect connections with the people that are being served, so that together we can really identify, again, what are the priority determinants of health in a specific community and how can we best address them. I think one of the early, I heard mention of developing a screening tool. So as we think about screening tools, I think if we create a standard screening tool across the pharmacy world, one thing we might want to think about is how do we build in the flexibilities to become a local support? And then how do we build in the opportunity and really create the infrastructure across our organizations that allow for the consistent and continuous feed of the patient and the family member into our programs? A screening tool is an excellent place to start with this. So bringing in a group of local community members. In fact, we did this recently here in Los Angeles. We had a researcher who was working on a vaccine come to Patient Family Advisory Council and say, we really want to test this. We need to test it in the African American community here in Los Angeles. How do we do that? Here's our flyer. And we had some of our African American residents in the meeting and say, if I read this flyer, I'd go running the other way, because it didn't really address all of the history that that we have here in LA County in our African American community. And so those kinds of really brass tacks, I think, can increase our efficiency of these efforts. They can increase the effectiveness of these efforts and really get us towards meeting the needs, the social determinants of health. So I'll leave it there for the moment, but I have a whole lot more to say.
Well, I have, thank you very much for joining us and sharing all of that. There's so much. I've been feverishly taking notes of points that I want to kind of revisit and definitely connect amongst our panelists here. And one point there that the initial question was, where are the patient's heads? What's the patient's priority? And it was, how do I get my meds? And it comes back to one of the comments that was shared from our audience that says people often underestimate how critical food security, homelessness, and social isolation are to medication adherence and healthcare utilization, especially now. So thank you very much for those relevant comments that Libby has integrated in, and our audience are all on the same page here. Another point I want to revisit and then bring Helen into this conversation is really, Libby mentioned a mother that was looking for that convenience and cost savings. And so, Helen, as working with a health plan that's based in New York City and has a pretty close relationship with the population there, as well as with the community pharmacies, what social determinants of health is a health plan interested in offering to be conveniently addressed at the community level?
Great. Thank you, Lauren. Thank you, PQA, for giving me this opportunity this afternoon to speak with all you. Really excited to talk about this topic. We are very close to this topic. As you can understand, we are based in New York City, so we have a very close pulse on what is happening within our community and within our membership. What we realized during COVID, obviously it bubbled to the top, but what we continue to really understand is that the reason why our members, our patients, are non-adherent to their medication isn't because of really solely the medication. It's about other things that are happening. And we realized that our food insecurities, housing insecurities, health literacy, not being able to really understand the severity of their disease, and that these are medications that need to be taken chronically in order to avoid further deterioration of their condition or just ER visits and inpatient hospitalizations. And what we've realized is that working with our pharmacies and our providers is that our members, when they are visiting and these very very accessible outlets. For example, the pharmacy is located in the communities that our patients live in. They speak the language that our members speak. They find comfort in knowing that they share a culture, a language, and so trust is built. And so the community pharmacists are the ones that can really assist in these various issues as it relates to food insecurities. They can direct members where there's a food bank, housing insecurities, For example, also, what are some ways that they can sign up for various city programs in order to have other costs covered? For example, water bill, their electric bill, things of that nature to offset the cost of them to stay on their medication, because obviously there's some copays associated. At Health First, we have a great team of individuals that is headed by one of our medical physicians, and clinical partnerships has taken a real front and center role in partnering with our providers in our communities. And again, the providers are in these communities where our members live and breathe. And so during this time, they've been able to identify, what are the barriers to them to getting their medication, staying on track, being adherent. And essentially what we've provided are tools in order for them to guide their members, patients, to several solutions. However, what we found is that it can't be a one-way conversation. We've realized our members have a very difficult time navigating the healthcare system, Health First in general, or just general life in some instances, depending on what they're experiencing. And so some of these services allow for there to be patient navigators that work with our patients in order to guide them to solutions that fit best for them, and then really just allow for that follow-up. And we're really excited about it because it takes away from that one-way conversation that we would potentially have if we were posed with an issue that our member is communicating to us and say, well, you can go here and there and possibly get a solution. This offers an alternative where we're closing the loop on potentially what the issues are. So it's really exciting, and Health First has a real big footprint in the community. We're really excited to work with our providers in order to allow them to have access to different types of resources and platforms for them to access when they are faced with members that vocalize these different types of issues as they relate to their health. The last thing we need is for them to worry about when they're getting their next meal. And so by providing all these services, we're able to keep them on track with their medication, which is really, what we're focused on, and really work with our pharmacies in order to do that. So I know we've referenced COVID. Obviously, it was a huge occurrence for all of us to navigate. It was very difficult, and we heard the same. How am I able to get my medication? And so what we found is that community pharmacies were doing their best. However, the provider offices, because of issues, were closed. And so because of that, we needed to rely heavily on our pharmacies, and then looked elsewhere for other types of pharmacies within our community that is able to do the delivery. Many of our members were afraid to leave their homes in fear of COVID. So we needed to provide some alternate methods for them to receive their medication, whether it's through delivery and through small pilot programs of offering a courier service. So we found that was an issue that rise to the top during COVID. We really tried to encourage our members to vocalize whatever issues were happening. We were doing this very intimately with some of our member communications, especially with our pharmacy technician outreach program that we have in place to help with STARS. But during COVID, it was really centered around, how are you? What's going on? How can I help you solve whatever issue that you're having? And our techs were able to navigate different platforms that offer solutions to help. But again, they found themselves really just trying to connect the dots to offer various solutions and really help the member, because we realized they can't do it on their own. So during all this time, we really come to realize that looking for solutions around social determinants of health are really standing with our members, with our patients, and ensuring that they do receive the right type of assistance that will solve or somehow guide them in the direction where it's not an issue for them and they can focus on their health, staying adherent to their medication, and really staying out of the hospital. So that's what really we realized during all this time, is that sometimes it needs to be a white glove service. And if we do it now and we're able to help our members, then hopefully they can take that lead on their own to reach out and find those solutions.
Absolutely, absolutely. Thank you very much for that, Helen. Again, we're connecting so many dots here between our panelists as well as the audience comments. Bubbling to the top here is proactive SDOH screening with local resource referral is key, and community pharmacy has a great opportunity here. I heard numerous times from Helen about those resources, giving those resources out to that community, into the community with those providers that have the relationships. Another thing I heard from Helen here is related to health literacy and a language and a culture. Maureen and I were preparing for this panel a few days ago, and during it, she mentioned the culture of science, and she mentioned it earlier in our panel here, and I did the typical pharmacist motivational interviewing tactic, and I said, tell me more. So Maureen, tell us more about the culture of science and how it all relates here to SDOH and addressing SDOH and these resources.
Sure, thank you. When I think about the culture of science, I would say that the average person is not all that bonded with the culture of science. What we bond with as humans is we bond with people who we think are accessible to us, people who we think we can trust and who genuinely want to try and help us with our concerns, very much like what Helen was talking about earlier. And we bond with people who we think will be pragmatic and practical in helping us solve our problems. And so what that means many times is that it's the boots on the ground, so to speak. It's the person who's maybe on the line, who's the patient assistance provider. It's the healthcare worker in the community. It's the local community pharmacist, or the pharmacist maybe on the PBM, or maybe on a care management phone line. It's those people who are directly interacting and connecting with patients, who very much, I think, are messengers who can not only potentially help with the social determinants of health, like getting access to our medication, or getting connected up with a food bank, or getting somebody to deliver us groceries, but are also the people who can be trusted by patients to actually help them better understand their medications, and to have trust in the therapies, the vaccines, the personal hygiene and other initiatives that we need to take so that we can contain COVID, and also the medications that we need to be taking on a regular basis to manage other acute conditions or chronic conditions. And I think it's really important. Somebody this morning talked about the fact that training is sometimes needed to help with that. And I think that's really right on. I think motivational interviewing, tips and tools can be very helpful. I also think actually shared decision-making tools and training can be very helpful as well. And part of the reason why I say that is because different people respond to different kinds of messages. And I think really researching the patients that we're helping, understanding them from a demographic perspective, from a social determinants of health perspective, from a psychographic perspective, what are their attitudes, values, and needs regarding self-care? All of those things become very important, and it becomes vital for us to research that and also to help support the people who are interacting daily to help address social determinants of health, to have messages that are going to resonate with their patients. And different patients, as we all know, resonate in different ways. One of the speakers this morning was talking about the different kinds of circumstances that people might run into, and how you might help different patients differently from an SDOH perspective. And what I would say is think about, for example, the individual who really is very balanced. They want to get all their information from multiple sources, and they want to really decide for themselves what's best for them. That kind of individual might respond very well, for example, to shared decision-making and to messages about their condition and therapies that helps them to be able to balance what's best for them from their perspective. Another patient might be someone who thinks of themselves as invulnerable or invincible. They want to do what they want to do now when they want to do it, and they're not necessarily real open to behavioral change, or particularly when it comes to their health behaviors or some other behaviors. And so that kind of individual might do very well with motivational interviewing, where one isn't pushing against them or arguing against, trying to dispute their beliefs, but rather helps them to tap into their motivations, what's most important to them. to motivate them in some way to make some changes in their health behaviors. And what I would say about that is that many times the influencers, the social influencers that someone was talking about earlier, may be the people in my community who are health workers, or my local community pharmacist who I also see at my kids', baseball games. That's the kind of person who may be most likely to influence me. And further, it may be my family members. So I might be more willing to change my behavior, not so much because I'm really concerned about myself, but more because I'm concerned about my family, or how something that I'm doing may impact my family. So thinking very carefully about how we approach patients, and giving additional tools for the various community pharmacists, healthcare workers, care managers, and so on, can be very important. And also supporting them, equipping them with the messages that are going to have the greatest resonance and connection also becomes important as well. Particularly if we're going to address the epidemic that we're dealing with, where there's a great deal of misinformation and mistrust, unfortunately, about various therapies.
Absolutely, absolutely. And again, connecting in our audience comments here, Maureen, you mentioned those tools and the training. There's also this great desire to standardize a screening tool for SDOH across healthcare settings. And then, of course, we are needing to allocate resources to identifying and prioritizing where resources can be applied best in this space. I think that very much aligns with what Helen was speaking to us about. And so, as we continue to look at our comments here, a tool to identify local resources for addressing social determinants of health, which can be different geographically, would be helpful. Again, hearing from that call that Helen has certainly addressed, and very much what's on the forefront of patients' minds there. So as we come to the end of our time here with our panel, we've covered so many topics, and I want to dive into so many, but we're unfortunately limited to time. So as we're wrapping up here, starting with Libby, tell us, Libby, SDOH is a huge, very broad topic. We have talked about a lot. Where do we start? The resources are are limited by the different stakeholders that are in play here, but where do we start? Libby?
Great question. And so I think the good news is you don't have to do it by yourself. And the good news is your starting point may not be the community starting point. And what I mean by that is there are organizations in your community that address food insecurity. There are organizations in your communities that serve the homeless. There are those. What the first steps are is partnering with those organizations. I think the community health needs assessments are a really underutilized tool in that arena. So, pulling those up and dusting those off and seeing what is in your communities, and then really extending. So I think that's the first step. I think extending yourselves into the communities and recognizing all of the good work that's going on. We're fortunate enough to work with a family resource center here in South Central Los Angeles, an area that, with our best of intentions, we wanted to go in and get people engaged in their healthcare, but had to recognize that we didn't have the credibility, the trust that's pivotal in community work, trust. And so we didn't have that. We needed to partner with those trusted community members, and certainly the pharmacists are essential in that. And so I think looking at who's in your community and then partnering and then building the infrastructure again to be continually informed by the patients and families that you're serving. I think that's critical. So giving resources, putting it into your organizational structure, moving from feedback into continuous feed, so that together we can really build the community around those social determinants of health. And I just would love to mention really quickly how critical language is. You've heard from it in terms of culturally how people want to be approached and the language that resonates. But I will say that by and large, across our PFA network, as diverse as it is in different regions of the country, the term adherence is really loaded. It's very loaded for us. It's a very, if you ask me, are you adhering to your medication? Well, yes, of course I am, because that's what I'm supposed to do, right? There's a power differential. And so that's just one example, but you've heard me talk today. I haven't used that term yet. I'm talking about access. And so I think that's one of the very first steps that patients and families can really help health systems and organizations with, is just getting down to, let's get some common language so that we can move forward together really effectively.
Excellent. Helen, same question. Where do we start? Where do we start here?
So I think being from New York City and having such a huge, living in a cultural whirlwind of different types of languages, people's backgrounds, I think for services to be adopted, to be utilized, need to be tailored specifically for those types of individuals in order for them to trust that those types of services will be of assistance to them. What we've also understood through some of our community work is that our members get a lot of their information from non-clinical areas, like their church group, the barbershop, when they go to the supermarket with their girlfriends and they're talking about different types of therapies on treating X, Y, and Z. So understanding that individuals will seek different types of alternative methods of treatment from non-clinical folks, and having pharmacists and providers that are close to that culture can speak to members and patients about that and identify with it, and through that come with really a member-centric solution that is something that the member patient will commit to and follow through and utilize as a resource to solve whatever the issue is, because it's something that the member feels comfortable to actually execute on. So to have that balance, I feel is key. The member has to buy into it, right? They have to find what's in it for me in order for it to solve whatever issue that I'm looking for. And really having the guidance of our health professionals in the community that can relate to it, again, builds that trust in order for members to then keep coming back, right? And that's what we want. We want patients and our members to be engaged in their health journey, to really seek for guidance when they need it and know they have a trusted healthcare professional that will guide them in the right direction.
Excellent. And Maureen, here in the final 25, 30 seconds before we have to transition, where do we start from your perspective?
You bet. So as I think about population health management and the incredible amount of needs that we have, a key piece of it is how do we make it precision population health management? And analytics becomes very important. Finding the individuals, identifying the individuals by their key therapeutic areas or disease states, and identifying what are their specific, most pressing social determinants of health needs. So that can be done through analytics. It can also be done through screening, and it can also be done through contact with people who are in the community. I've heard a lot of talk today about the people in the community are the people that you're most likely to resonate to, and I think that is just so important. And I've also really want to talk about messaging as well and how important that is. And Libby really drove that home when she spoke about the issue of adherence, that adherence is not how people typically want to. That can be sort of a guilt. It's a clinical term, and it can also sort of be a guilt-tripping term if you happen to be talking to a patient or a family member in that way. It's more like, gee, how are you doing with are you having those side effects that you used to have? Are you still having, the heartburn? Those are the kinds of questions that are useful as opposed to, are you being adherent? So I think there's adherence can be approached in lots of different ways. It's through that connection that we have. It's through the messaging, the types of phrases and the types of questions that we ask. That's where motivational interviewing comes in. And I would also say that telehealth is a whole new technology that we can really leverage as well in helping patients to be able to use it too.
Well, I want to ask Richard to push us back 2 slides because one of the audience comments that came in regarding the pharmacist in addressing SDOH, because it's immediately relevant and excellent transition to our next session. But I want to first thank our panelists, Libby, Helen, Maureen. Thank you all for joining us and lending us your perspectives. We encourage our audience to continue to submit comments and questions to us. We want to hear from you. But as we transition to our next session here, we can look at this comment that was submitted by an audience member. So the pharmacist's role in addressing SDOH has not always been well defined, and published literature suggests pharmacy curricula do not consistently integrate components of SDOH. I think this resource guide has potential to help fill this gap. And boy, does it ever. And I want to make sure that we transition here successfully so that Chris can come in here and really get your perspectives on where PQA should be taking the social determinants of health resource guide that we plan to develop. But first, so here at PQA Studios, we have been operating in a bubble as we've been planning and preparing for the PQA Leadership Summit. We're not as intense as the MBA, but we have been taking the precautions in order to maintain our social distance and prevent the spread of COVID-19. We're also going to take those precautions as we transition to our next session. Okay. Stay back.
Well, I want to thank you all for bearing with us in this era of COVID. Even our stage transitions take a bit more time. And thank you, Lauren, for the introduction, and a big thank you to our panel and all of those who've been engaged with us throughout the day today. And we thank you again, Lauren, for helping us ensure social distancing, of course, with that tape measure and all. You know, we've had a great series of discussions today, and I want to thank all of our audience members for tuning in and for your continued engagement. And as we've heard throughout the day today, there's so many opportunities to address the social determinants of health. And with the question that Lauren just posed at the end of his previous session, really that stands before us is, where do we start? And this is where we're looking to you, our members, today as well. Our focus on SDOH and its place as a strategic priority for us in 2021 is driven by the fact that there is not an existing resource focused on SDOH interventions as they relate to medication use quality and pharmacy services. We here at PQA hope to build that resource. To give us focus areas heading into 2021, we need the help of you, our members, to guide our work through the polling exercise beginning in just a few moments. You have the opportunity to answer 3 questions about the 7 SDOH areas presented today and featured in the summit's pre-read document. To help us better understand the perspective of our members, we also invite you to share which sector you represent. This is not a formal vote, and you are not being asked to provide the official position of your organization. However, this is an opportunity to capture the sense of our diverse membership. This is an opinion poll, and we want you to be guided by your experiences, your insights, and your priorities, both as an individual and in your role as a healthcare quality professional. We will only report aggregated scores and will not be tracking or reporting any individual answers from this poll. The collective input you share will serve to direct our team as we build a resource guide in the year ahead. We'll dig in deeper on these issues with subject matter experts over the coming months and years. However, in case you haven't seen enough live results this week, we'll take a look at our scoring results in the latter part of this session that you all have input in. Here's how the polling will work. You will have 3 minutes to answer each of the polling questions. The first 3 questions will focus on the SDOH areas we have discussed today. To begin, we want your input on priority areas for improving medication use quality. For each SDOH area, you can rank the area as having a low, medium, or high impact. There's no right or wrong answer here, but of course we want your opinion. You are limited to answer 3 high impacts for up to 3 of the 7 areas. We recognize that each of the areas is very important in its own regard, but to help us determine the key focus areas for PQA to address first, we ask that you limit your high impact answers to only 3 areas. You may answer medium and low impact as many times as you see fit. Let's take a look at a couple of examples before we begin. For instance, as you can see here, if I thought that screening, food security, and social isolation had opportunity for highest impact, I would mark these as high. The rest are filled as medium and low. In the next example, I may only think that 2 areas have the opportunity for high impact, such as safe and decent housing, as well as transportation. So I mark these 2 areas as high. For other areas, all other areas, are marked medium or low, as you can see here. And now it's your turn. We recognize that you may not need the entire time allotted to complete this poll. If that is the case, take a quick break to grab some refreshments or just stretch at your desk. Just be sure you're back within 3 minutes. If you scroll down from this video stream, you will see the polling questions. If you are in full screen mode, exit full screen and then scroll down. Please take a few moments to answer, and be sure to click submit when you are finished with the poll to ensure your answers are recorded. If time runs out before you click submit, not to worry, as your answers will be recorded as they stand at that time when it runs out. And of note, if you are having difficulty accessing the poll or seeing the poll, please contact the tech support in the lower right-hand corner of your screen, and they will be able to assist you further with sending you the direct link to the poll. So go ahead, take those 3 minutes, and go ahead and answer that poll. Looks like there's about 1 minute remaining, and again, be sure to click submit when you are finished with the poll to record your answers. And the poll is closing, so your answers will be recorded as they sit. if you have not already submitted on those answers. Please scroll up on your screen to return to the stage if you've not done so already. And welcome back. Next, we want your input on the ability of pharmacists and pharmacies to address these SDOH areas. The same 7 SDOH areas are present for this question. We are also using the same scale. For instance, if you think pharmacists or pharmacies have the opportunity to greatly impact an area, you will mark the area as high. Once again, we're limiting you to 3 high-impact answers to help PQA focus its efforts. To answer this poll, scroll down from this video once again and take a few moments to answer this question on the ability of pharmacists or pharmacies to address each SDOH area. Be sure to click Submit when you are finished to record your answers. Once again, if time runs out before you press Submit, your answers will be recorded as is when time runs out. All right, everyone, it looks like there's about 1 minute remaining in the poll, so be sure to click Submit when you are finished. And as the poll finishes here and your answers are submitted, please return to the main stage by just scrolling up on your screen. For our final SDOH question, we want to know what our members currently do for each of these SDOH areas. You will have the opportunity to select multiple answers for each SDOH area, including screening, referral, and intervention, depending on what you are aware of your organization doing. Let's take a look at an example together to better understand this polling question. As we can see here, for cost of medications, if my organization conducts screening and has an intervention associated with that screening, then I would check both screening and intervention for the cost of medications row. Also from this example, my organization does not currently have screening, referral, or intervention for food security, so I leave that row blank. However, for social isolation, My organization conducts screenings, has referrals, and also has a direct intervention to address this SDOH area. So I check all 3 boxes in that row. With that in mind, it's your turn. Scroll down from this video and take a few moments to answer this poll. We will give you 5 minutes this time to ensure that you have time to answer the poll completely. Please click the Submit button when you have completed the poll to record your answers. There's about 1 minute remaining with this poll, so again, be sure to click Submit when you are finished answering. All right, and as time runs out here, please click submit or just let your answers be there when time runs out to be recorded for us. Finally, to help us have an idea of who participated in the polling today, please fill out a simple multiple choice question on which PQA member sector you identify with. Scroll down one final time from the stage to complete this polling question, and we'll give you 2 minutes to quickly complete this final poll. All right, looks like we have about 1 minute remaining here with this poll, 1 minute remaining. All right, and the poll is closing, so please click submit or let that time run out, and your answer will be automatically recorded at that time. I want to thank you all for your input today. As a member, your input is of critical importance to PQA as we seek to develop an SDOH resource guide. Now, let's take a look at today's results from your input that we've had in the last few moments. First, in the areas of opportunity to improve the quality of medication use. And from your answers here, taking a look live for the first time, I'm along with you at this time as well, within our impact to quality on safety and medication use, we can see that screening for unmet needs and cost of medications, as well as cultural and literacy barriers, were our 3 top areas according to your votes. And the ways that we arrange these here, you'll notice that there's no scaling along the bottom, but these are all relative to one another, depending on how you ranked them. And so a higher ranking resulted in a higher scoring to that particular area of social determinants of health. You know, I find this really interesting too, just from what we've discussed throughout the day today with our varying panelists. You know, this is really echoing a lot of what we've been hearing about the impact that we can have specifically on these 3 areas, from the screening aspects and leading to those referrals within these other areas. And certainly this doesn't detract from the other areas that were slightly lower here. As you can see, relative to one another, these were all very close to one another. And we really do hope that this will help us to begin to shape out what's of highest impact that we can have on that quality of medication use for our members to be serving within their communities in the year ahead. So I'd like to go to the next slide as we're looking at the results, looking at the ability of pharmacists or pharmacies to impact areas within the social determinants of health. And so what can pharmacists do about this? And again, looking at these together live here, I can see that very similar overlap within those 3 areas, and even more emphasis, I think, here on really where pharmacists can have an impact. Screening for these unmet needs, as you can see here as well, with the cost of medications, as well as those cultural and literacy barriers. And so that overlap really helps us here at PQA to see that there's kind of this clear top three, if you will, areas to address first, if you will, once again. And again, we realize that pharmacists can have impacts across these areas and on these other areas as well. But as we look to focus our efforts and really start to shape out this guide for the use of you as a member, we really do hope that these high impact areas, as well as the high ability of pharmacists to be using our resource guide, will really allow them in order to have that impact and utilize this guide in a meaningful fashion within your communities as well. And so finally, to see what our members are doing here as well, and what you're already perhaps doing within these areas. And so we'll go ahead to our final poll here that we'll take a look at today. And you can see that our screening is in gray, our referral is in orange, and our blue is our interventions here. And it's really great to see, once again, interventions as far as cost of medications. As we talk about having, again, high impact on medication use quality, it's wonderful to see that our members are already having interventions in place for these things. And we will be, again, referring to our members over the year ahead as we build this resource guide and hope to bring folks together on this to make it meaningful for use across the country with the quality of medication use. So in addition to that, looking at our live results here once again and seeing these in real time with you, looking at, again, our cultural and literacy barriers, conducting quite a bit of screening as well as interventions there as well. Food security, having a lot of referral pieces that go on, which again, we've heard about throughout the day today when it comes to food security. Looking at housing, once again, with those referrals, and I think it goes back to when I was listening in on Lillian and Jill's conversation this morning with Richard, really, the interventions that you can have that help, again, from the pharmacy perspective, just having easily accessible healthcare providers that are available to their patients and can refer them to the appropriate programs here as well. So it's great to see both, again, within social isolation, transportation, lots already going on once again as far as referral, intervention, and screening across the board there. And so thank you all again for your input today. This is extremely meaningful, and we hope that this has been insightful to you all as well, that you're not alone in these efforts, that your other members of PQA are also participating across the board in trying to address the factors of social determinants of health, and that we will be coming together again in the years ahead to try and form this resource guide for the use of our members as well. So thank you again for your input. It's, as always, is a very high value to us, and we will be, again, continuing this work in the years ahead. Now, with that in mind, we'll wrap up this session here, and we'll have a quick word from our sponsors before we hear from Richard Schmitz as he hosts our final SDOH conversation of the day.
The Enliven Health patient engagement platform integrates intelligent clinical solutions and digital communications technologies to ensure increased member adherence, retention, and quality scores. At the same time, Enliven Health Solutions empower health plans to effectively manage risk and significantly reduce costs. A national study conducted by researchers at Harvard University, health plans and pharmacies using Enliven Health Solutions have achieved a 9% reduction in hospitalization and ER visits. To learn how Enliven Health can help you measurably improve member health outcomes and strengthen plan profitability, visit enlivenhealth.co. IQVIA is a global leader in protecting individual patient privacy. The company uses a wide variety of patient-enhancing technologies and safeguards to protect individual privacy while generating and analyzing information on a scale that helps healthcare stakeholders identify disease patterns and correlate with the precise treatment path and therapy needed for better outcomes. IQVIA's insights and execution capabilities help biotech, medical device, and pharmaceutical companies, medical researchers, government agencies, payers, and other healthcare stakeholders tap into a deeper understanding of diseases, human behaviors, and scientific advances in an effort to advance their path towards cures. To learn more, visit www.iqvia.com.
All right. Welcome back to the summit. It was great to see everyone's opinions and experiences on the SDOH factors that we just ranked. I'm excited to host our closing SDOH discussion. Most of today's conversations have focused on SDOH practices already in play. We wanted to use this time to look forward, to what we might see in coming years as it relates to SDOH policy, initiatives, and national trends. So joining me is Dr. Philip Alberti, Senior Director of Health Equity, Research and Policy at the Association of American Medical Colleges. Dr. Alberti is a passionate advocate for eliminating health disparities. He's focused on how research, education, and training can help us build our nation's capacity to improve the health of all. And across this work, he keeps an eye on trends and promising practices. That's why I thought he'd be great to help us take stock of where SDOH efforts are headed. Philip, thank you for joining us today.
So thank you, Richard, for the invitation. I've been able to watch all day. I've learned so much, and it's so exciting to hear the incredible work that pharmacists and PQA are galvanizing. So thank you.
Great. Well, I thought we were going to start today's conversation with a reflection on election results, but it's premature to do that. So we're going to talk, to start here about the polling results that we just had here. And so, we looked at a number of factors where the greatest impact can be had and where pharmacists in particular can play an important role. And it appeared that there were kind of three specific areas that ranked most high: screening for unmet needs, addressing cost issues, and cultural and literacy barriers. So I wanted to give you an opportunity to reflect on the issues that we just ranked and the results that we've seen from our members.
It's great. So I was writing the results down as they were coming in, and the 3 of the 6 and the 7, they all make sense. They're all targets of, I heard a previous panelist talk about community health needs assessments. All of those factors light up there. And we think about national efforts to begin to align data collection, transportation, food access, housing instability are the 3 main targets right now. One that I would add that wasn't part of the poll that kind of undergirds all of the activities that folks are responding to. I think the single biggest thing that practitioners of any kind, pharmacists, nurses, physicians, can really think about is trust building and becoming trustworthy. Because all of our screening efforts, all of our referral efforts, all of the interventions that we develop and deploy will not be successful, will not be effective unless we are able to really address tackle head-on issues of longstanding mistrust in public health and healthcare, in medications and vaccines. It's in high relief right now. And so I think pharmacists are also uniquely positioned to really build those kinds of trusting, bidirectional, authentic relationships with patients and communities in service of all the other social risk factors that you've ranked today. So I wanted to add that extra one in.
That's a great addition. I think trust and the relationship factor that patients have with those who care for them is ultimately critical. About 2 weeks ago, you had a LinkedIn post on SDOH, and you said that really what is being asked of the healthcare system today is akin to boiling the ocean. We're asking people to both care for people's traditional healthcare issues and challenges while simultaneously addressing SDOH. And it really is a daunting, if not overwhelming task. And in light of that, where do we start? Where do you suggest that we begin in something that's actionable and approachable?
Okay, well, first, I appreciate you reading the post, maybe you and my mom, so that's great. So I appreciate that, Richard. I think the post was titled something like 3.5 questions that healthcare and our partners have to really answer. And so I think my general feeling, someone who's been in this field of health equity for about 20 years and who's been kind of sitting in an academic medical post for about 9, I think there's the excitement and the passion and the urgency has resulted in a lot of work, which is incredible, but maybe in the absence of real thoughtful planning. So before we concretize all of these efforts, I just had some fundamental questions that I think we as one node of the health ecosystem, right? Healthcare is just one actor, one sector in the much broader ecosystem that we have to come together to answer. So the first question is what's the goal of the healthcare system's activity in this space? Is it healthcare equity, right? That 20% of what makes a person or a community healthy, quality, access, to make sure there's equitable opportunity? Are we going to focus more broadly on health equity? So adding in that additional 60 or 70% of social environmental factors? Are we going to go all the way upstream and really focus on fundamental causes of racism, of classism that then impact social determinants and social risks. So the way that I think about that is, what's the activity that the healthcare system is going to undertake? Are we really going to focus on screening and referring for individual patient needs, right? I'm homeless. Are we really going to focus on the community characteristics that resulted in that homelessness, like lack of affordable housing? Or are we going to focus on the policies that create that maldistribution of affordable housing, like racism and redlining and lending practices? And so I think we just have to first keep our eyes on the prize. We have to really understand what the level of intervention is going to be, and it might be all three. And then we have to start asking ourselves about who on the care team should have the competencies to do that work, either the healthcare equity work, the patient level intervention, the community level intervention. It's not just about the MD or the DO, it's also about the pharmacist and the community health worker and the nurse and the social worker. And I think we've heard from your members today that we haven't really defined some of those skills, some of that material, some of the activities, and who's leading that from the healthcare side. And then what gets me most excited is the final question: do our healthcare organizations, do our hospitals actually have policies and programs in place that would allow the right healthcare provider for the right patient at the right level to display and develop those competencies? Do we incentivize upstream work? Do we include that in merit and promotion activities? Do our IRBs easily allow for community or patient co-investigators and the kinds of research that we need to really understand what's going to work? So are our organizations competent in allowing this kind of work to take place? And so those are the questions that excite me the most. I love the spirit and doing the work and running forward, but let's make sure we're keeping our eyes on the right prize and that we're developing the right skills with the right team members.
Great. That's really helpful. And you mentioned the issue of racism. And this year, issues of structural and institutional racism have been discussed and approached more than ever. And that's a great moment of progress for us as a healthcare system. And we wanted to account for that in our work here, but we wanted to be cautious because we know that you can neglect or even exacerbate some of the racial and ethnic disparities in addressing SDOH if you're not careful, you're not advancing the two appropriately. How do we advance and improve SDOH while tackling racism issues and not making them worse?
That's a great question. Racism, as my mentor would call it and does call it, is a fundamental cause, right? It's a cause of the cause. So we think about the answer that I was just talking through, right? So if the patient's social need is I'm homeless, well, a reason for that could be because of the community social determinant of my community has no affordable housing. And the fundamental cause there is racism and zoning, lending, building. And so if we're really going to go to the root of the issue, that's the place that we have to go. Racism, classism, homophobia, all the isms and all the phobias. From the AAMC, I can talk about what we've done and what we've put out there. So we launched our anti-racism kind of framework that sits on 4 pillars for our organization. So the first is really self-reflection, not only about thinking about our own biases and the own stereotypes that we apply, but also our position in our work, in our community, how others perceive us and what role we can play. Number 2, it's really looking at our own internal organizational policies and practices to make those explicitly anti-racist. So how are we making hiring decisions? Where are we looking for job candidates? Do we have pay equity? Are we really thinking about promotion in an equitable anti-racist way? So getting our own house in order is that second pillar. As a member organization, of course, it's working with our member institutions to really think about racism in medicine. So we heard today, there was a talk about predictive analytics. Well, how do we ensure that we are removing biases from the algorithms that are used in predictive analytics? Who's coding them? Who's interpreting them? How can we make sure that they are explicitly kind of bereft of all racist overtones? And then, of course, last is our work on the national stage. I think it's really important for organizations like PQA, like AAMC, to speak with a loud voice, to call racism out by its name, to really begin to build national partnerships and coalitions to address and to be unafraid of having uncomfortable conversations in the course of not just our SDOH and upstream work, but all of our work. But your question, all of that takes time, right? That's a long game to get to that place. And right here, right now, we are doing work to address patient social needs. We are doing work to work with communities and their social determinants. And so my gut tells us we have to also make that work in the here and now explicitly anti-racist. And for me, the building block of that, step number one, we've heard the last panel in particular talk about this, it's really about community and patient engagement. It's really understanding that we as scientists, as pharmacists, as clinicians, have no inherent expertise in navigating social and health injustice. But the communities, the patients that we work with and serve, they are experts. They have developed over centuries of navigating social and health injustice, assets and resources and tactics and strategies. So if we are truly going to be anti-racist and authentic partners in this work, we need to approach it with humility, with transparency, and with an understanding that we as healthcare professionals have as much to learn from our patients and community members as they have to learn from us. And only through true partnership, listening, and improving our bi-directional communication and connection skills can we even begin to dismantle racism in our structures and systems.
That's great. I want to share a comment that's come in from our viewers, and a reminder to our audience, if you have comments or questions for us, feel free to enter those in the box. Have my pad with me here, and we'll bring those into the conversation as we can. But there's a comment about the issue of tools, and there's been a lot of discussion today about the need not only for pharmacists but for other care workers to have appropriate tools to help address SDOH, both through screening, interventions, referrals, the different ways to address this. Can you talk with us a little bit about what you see as the need and the opportunity to develop tools that can be better used by healthcare workers?
So again, I'm gonna repeat myself. I say, tools to do what? Is the tool to ensure that we are not creating healthcare inequities within our walls? Is the tool to develop better community connections in service of social justice or health equity beyond our institutions' walls? So I think first and foremost, it's really right sizing. The kind of tools that we're talking about and the goals of those tools. There's been a lot of conversation today about screening tools and whether we need standardized tools and how we can then make adjustments based on local salience and need. And I think we need to be able to walk and chew gum at the same time. Maybe we'll talk about policy in a minute, but there's a real policy imperative for a standardized national data set that captures demographics, social needs, and social determinants in ways that allow for aggregation to track progress, et cetera, and that allow for smarter policy so we can avoid some of the unintended consequences that Dr. Jane mentioned about star ratings and maybe isolate true quality differences better in our quality programs. That said, we need to develop those tools in partnership with communities and patients. Even if the data fields are the same, the ways in which we go about gathering data could be very, very different. So we need to really think about what clinical workflows are going to yield, or public health workflows, or criminal justice workflows, because we all need these data. These are not healthcare data, and that's the other step back big point that I would make, is that this data collection tool should really be a multi-sector endeavor, because it's the same set of information that we need as healthcare providers, as our public health partners need, as our urban planners need to really make coordinated efforts for progress in this space. So I think we need to understand from a patient perspective how we don't stigmatize in the screening and referral process, how we make sure the data that we get are valid and self-reported. And so until we deeply partner with patients to say, is this a primary care physician doing the screening, a nurse, a triage, a pharmacist, a patient portal? How do we really understand the benefits and limitations of those modalities? I think it's a partnership of tool development to meet federal and national policy needs, but also local on-the-ground urgencies. I'm not sure if that 100% answered the question, so I'll pause and check with you again, Richard.
I think it's a great answer, and I'm glad that you brought up the issue of policy and the issue for the need for a national, accessible, consistent data. We've been talking in Washington for decades about this now, and I wanted to give you an opportunity to talk about, what needs to happen? What are the barriers to overcome to allow for that data to be developed and to flow in ways that both patients and those who care for them can use them in helpful and consistent ways?
That's the crucial question. So one, my first knee-jerk answer is, again, it needs to be a multi-sector decision. It can't just be healthcare deciding on its own, here's what healthcare is going to collect. Because that is a very narrow definition of health. And these data points about individual demographics and social risks and neighborhood level social determinants are needed across our sectors to do coordinated multi-sector work. But here's something that I think is really interesting, because I think COVID has highlighted this need even more. So in health equity research, we divide kind of the science of this into 3 generations. So there's first generation health equity research, which is really descriptive epidemiology. Where are these inequities? Which populations? How big are they? Right? Second generation is more analytic epi. Why do they exist? What are the mechanisms? What causes them? What maintains them? And third generation is about the science of solutions, the evaluation science, the implementation science, et cetera, to really spread and scale things that are going to narrow these gaps. So in 2020, you'll remember for the last 6 or 7 months, we've had clamors for first generation data, right? Give me race ethnicity data. Where's the race ethnicity data? And while it's embarrassing, that we as a nation haven't made that investment to collect valid, self-identified race, ethnicity, and language data. Let's be honest, even if we had all the data on race and ethnicity, would it change our understanding of the story? Of course not. You could have asked any one of us in this room 2 years ago, pre-COVID, if there was a pandemic, which communities would be hit the hardest and why? We know this. So we have people, dying for third generation solutions while we're still asking for first generation data. And so I think what we need to galvanize is an effort that says, yes, we need demographic data, but let's be clear, race is not intervenable. Race is not a risk factor, racism is. So if we understand that there are inequities by race or ethnicity, there is no intervention for Black. And not all Black communities are the same. Not all white communities are the same. Not all Asian American communities are the same. So we need a data collection system that unpacks into individual social risks like the ones that you've ranked, transportation, food access, housing access, but also neighborhood characteristics. Because my own ownership of a car has impact on my health, but as does my community's access to public transportation. They're not the same thing. And so I think the barriers to getting that is who's going to pay for it. I think that's really an important question. Who's going to be responsible for collecting it? And then how do we, again, do this dance of a national standardized data collection when the processes are going to have to be locally tailored? So how do we do that kind of methodological tango to make sure that we're getting data that can be aggregated federally while each county, each city might do that collection in a very different way? This is no easy task. And so I think that a lot of AMC has been at the forefront, I think, advocating for this kind of national data collection strategy. There are efforts right now, Google funded Morehouse School of Medicine and the Satcher Institute to think about real-time data collection at the community level for COVID. There are federal initiatives that are doing very similar things. So I think there's a recognition that this is needed. But I do worry that as we've heard today and in many other conversations, as each hospital and health system does their own thing, and as everyone goes into their Epic or Cerner system and says, oh, let's make that our own, that sort of resonates with our community, that's important in spirit, but every time we do that, it moves us further and further away from a data set that can be aggregated for policy use.
Well, you mentioned the COVID pandemic, which has really amplified a lot of the issues, the barriers, the disparities that we already knew existed. Is there anything that the COVID pandemic has revealed or brought to light regarding SDOH that we weren't really focused on before?
Well, that's a hard question. It's hard for those of us that have been in it for so long to take a step back and imagine what the experience might be for those that haven't been plugged into the social impact of health for so long. So I'll give anecdotes from my people in my own life. I think there's been a lot of surprise that the inequities have played out in such stark terms in real time, where we could actually watch the inequities grow overnight as new data and new information came in. I think it's also been illustrative that it's really been a bipartisan awakening. I have to say that in my, I'll give a specific example. I attended a congressional briefing just about 7 or 8 months ago on maternal mortality inequities. Obviously a huge role for social determinants of health and fundamental causes, especially racism and misogyny, and the role of maintaining racial ethnic inequities in maternal and infant health. And I was flabbergasted and overjoyed to hear politicians, not all politicians, but politicians on both sides of the aisle talk with facility about social determinants, because I think if rural health and that focus has done anything over the last 3 or 4 years, and we could talk about diseases of despair some other time and what that really means, I think it's been an awakening that these are not Black and brown issues. These are American issues. These are issues that affect all of us. And so I think the more that we can make the completely valid point that health injustice, health inequity, and social determinants is an American problem and not a segmented problem, I think we can really make some bipartisan efforts. And I've been really surprised, pleasantly so, about how both sides of the aisle are tackling social determinants.
So you used the phrase plugged in earlier, and it kind of brings to life for me a comment that we've received related to the digital divide. Can you talk about the issues related to internet access and bandwidth access that is another barrier that a lot of individuals face, both in rural areas but even in the inner city?
Sure, and that's I am hopeful that telemedicine can absolutely be an important tool in the toolbox, but I definitely don't see it's a silver bullet. And I think broadband issue is access is the one that gets the most attention, I think. But there are also other demographic characteristics that are really related to inequities in telemedicine. I think the age divide. My mom, she has broadband access. Would I trust her ability to be able to access healthcare via her, version 5 or 6 iPhone? No, I don't think that's going to happen. I think language barriers is another huge issue when it comes to telehealth. How do we ensure real-time access to interpretive services, et cetera, in that modality? And I think trust comes back as well, and HIPAA and privacy, and who's going to see the visit. So I think broadband is crucial, particularly for frontier communities. I've been the data that I've seen about kind of racial ethnic data divide is that's really, really narrowed in the past 10 or 12 years. Almost everyone has a cell phone now, it seems like, that could be used for telemedicine. But I think certainly in rural and frontier areas, that's an issue. But I don't want us to lose sight of age barriers and language barriers as well.
We know that the SUH barriers that individuals face vary dramatically across the country, across communities. We've been talking a lot about scalable solutions. Given this range of issues, what do you see in this space that is truly scalable?
I think so I was trained in community engagement, so I know I'm a broken record when it comes to this, but I think what is truly scalable is working across communities, across sectors, to have open dialogue. I really do believe that this is the most crucial first step if we are going to figure out how our sectors, including healthcare, can come together to address these social issues, these social factors in our communities. There is not a lot of trust. It has been broken, or it has never existed. In many, many communities across this country, there has not been any trust. And so I think finding scalable solutions to brokering these conversations, to developing true partnerships, that's a scalable, needed first step. I think also communication is key, and also for healthcare in particular, how to partner from a place where you are ceding power, where you are willing to say, we are not the experts in how to navigate and mitigate these issues. We have to learn. We have certain resources, whether they are physical resources, financial resources, scientific resources, that are met and equaled by the resources in our patient communities and the broader communities that we serve and work in and live in. And so I think that stance, that self-positioning in this work, is a crucial and scalable solution that will facilitate and accelerate our work in truly developing interventions. That said, follow the money. So if we right, if we really want to incentivize work in this space, we're going to have to figure out how to incentivize financially work in this space. And I don't mean just the healthcare system. I actually think we're running the risk of putting too many eggs in healthcare's basket, because social determinants aren't healthcare determinants necessarily, or they're not uniquely healthcare determinants. They're also educational determinants and employment determinants, and determinants on whether or not you end up in the carceral system. So I think that we need to take that step back, partner better, incentivize all sectors to focus on this work, and then really strategize how we can rebuild or build anew trust with patients and communities to leverage their expertise in scalable solutions.
I think that's great to hear, and that's really part of PQA's focus, which is how do we build collaborations, across healthcare and beyond. And as you know, PQA is focused on medication use quality. And so we've been putting the question to all of our participants today, when you think about medication access, adherence, and appropriate use, where would you start in addressing SDOH to have a positive impact on those specific issues?
Sure. So I won't say trust again, even though I just did. That's number one. But I also think economics is a huge issue. And I think health literacy and numeracy is another huge issue. And I think both your survey showed this, but I think a literature scan would also show that pharmacists are particularly well positioned to build trust, to provide access to resources that might help mitigate some of the costs, to really spend the time needed to talk through issues of health literacy and health numeracy with patients and families and caregivers in a way that other members of the care team might not be able to. I also know there's a pretty strong literature about community health worker pharmacist collaborations that I'm really excited by. I think, leveraging local community members to partner with public health and healthcare actors to really triangulate action, to really build those bridges, to find a common language and to rebuild that trust. I think that's really important and hopeful as well. So numeracy, literacy, economics, and trust.
So PQA and our members, we're all looking for ways to expand and improve our work to address SDOH. And AAMC just released its strategic plan. And there's a part of that, there's a Center for Health Justice that you're going to be heading up. And I'm hoping you can kind of close this out by talking a little bit about that, how you guys came to that idea, and what insights other organizations might take from that in developing their own efforts.
Sure, thank you. Thank you for that shameless plug. The center does not exist yet, so don't Google it. We're in the ideation phase, so look out for the spring or early summer of next year. Our strategic planning process actually predated the epidemic. We have a relatively new CEO, so this process started in June or July of last year. And now, of course, we feel this increased urgency, given everything that's happening in the state of the world and the state of COVID-19. For those that want to know more about health justice, specifically, there was this wonderful paper that was written by a lawyer named Emily Benfer in, I think, 2015, that's been pinging around in my head, that's really planted the seed for this center. And there are 4 basic principles of health justice. It'll come as no surprise that the first and foremost is community engagement and collaboration and grounding all the work in lived experience. For the center, that could be everything from ensuring that we are conducting nationally representative surveys and research that we can then incorporate our compatriots' views on these issues into the work itself, all the way down to co-developing tools at the local level that can facilitate the kinds of collaborations that you and I have talked about today, Richard. It's also, again, pillar number 2, being explicitly anti-racist, anti-classist, anti-bias in all of the work and being explicit about it and walking that walk. And the final 2 pillars really focus on policy. So what policies, both capital P policy, federal, state, and local, but also organizational or institutional policies, which ones are proven through research and analysis to promote equity, to promote wellness? Let's do more of that and advocate for more of that. On the flip side, which policies, again, at all 4 levels, from federal to institutional, are shown through research and analysis to actually increase inequity, to increase illness. And let's be sure that we are advocating for the removal of those policies. You know, I trained in public health, and I'll close with this. My mentor and previous boss, Dr. Tom Frieden, where it showed that if you wanted to change population health, and health inequities are population health dynamics, right? People don't have a disparity or an inequity, a community does, a state does, a population does. So if you were to effectively intervene, the least effective interventions at the top of the pyramid, the ones that require all the resources but will not move the needle, are education, one-on-one education for patients, and clinical interventions. So if we're really serious about moving the needle on these population health social phenomena, we need to go all the way down to that base of the pyramid and ground the work in systems and structural change that's led by policy analysis and policy and advocacy work. And so the center is really going to try to do all of those things, not try to boil the ocean, you know, use Americans' perspectives to focus on 3 or 4 issues at a time. But that's where we're hoping to go. And so I look forward to having our next conversation, maybe after the center launches, and we can figure out how AAMC and PQA can partner in service of health justice.
Yeah. Philip, we would love to have that conversation. I want to thank you for your time today. Thank you for joining us. Thank you for your insights and your passion for addressing these issues. So we look forward to seeing how all of that work continues to develop. So I want to add my final thanks to our sponsors. We're going to hear another message from our sponsors. And then when we come back, Laura Cranston will deliver the State of the PQA Alliance.
CSS is a national leader in the design and operation of Medicare Part D medication therapy management, Medicaid quality improvement, and commercial and self-insured cost and HEDIS management, assisting over 70 healthcare organizations with program design, data collection, analysis, care coordination technology, reporting, and CMS submission services.
Good afternoon. Thank you again for joining us at the 2020 PQA Leadership Summit. The program has been robust, engaging, and very insightful to support our efforts in the year ahead. I recognize our very generous sponsors and the PQA team for all the energy and preparation that go into these virtual meetings. We are now fully 9 months into this pandemic, and it's been a year that will continue to be transformative on many fronts, from healthcare to social responsibility to addressing public health infrastructure challenges as we continue to work our way through this pandemic. Some of the changes we have seen made through emergency orders, regulation, and legislation have had positive implications for our healthcare system and for pharmacist-provided care services in particular. The steps that have been taken to allow healthcare professionals, including pharmacists, to practice at the top of their licenses has been strong, and we need to ensure that the expanded scope and innovative practices are sustainable. I hope that wherever you are safe, healthy, and thankful. Thankful for the nation we live in, thankful that we can gather virtually despite this pandemic, and most thankful for the frontline responders and for all healthcare workers that continue to care for the millions of individuals that have been impacted by this coronavirus. As we near the end of this year's summit, I wanted to share a State of the Alliance, as has become an annual part of our convening. Recently, we shared with our member organizations a headlines and highlights report, which reviews PQA's accomplishments over the last year. I'd welcome the opportunity to touch on the initiatives we were leading this year, all of which are made possible by you, our 250 members, our dedicated board, and our talented staff. On the measure development front, we've had a number of successes that are very close to completion this year. First, we have 2 important measures that will be up for a membership endorsement vote before the end of the year, as you can see here. Additionally, we're working on an important cross-cutting measure in the specialty space for turnaround time that is currently in testing. And we're also very excited about the Pharmacy Measure Development Action Plan. Our Pharmacy Measure Concept Advisory Group launched earlier this year and has prioritized measure concepts resulting in the appointment of technical expert panels to develop measures for pharmacies that focus on 3 key areas. We launched a companion effort with the Community Pharmacy Foundation to identify high-impact measures that can demonstrate the value of pharmacist-provided services. PQA is committed to developing pharmacy measures that address quality and measurement needs beyond the CMS Medicare STARS program. These measures will support value-based models of care across different lines of business, from commercial to employer-based programs, from regional to national payers, and to other innovative models in the market. PQA provides educational opportunities for our members throughout the year. From our national meetings to quality forums and webinars, we're working hard to keep you informed on current issues and emerging trends in medication quality, measurement, and implementation. Building on this solid foundation, we launched the Medication Use Quality Continuing Education Program in May. This program provides advanced training on quality measurement and strategies to improve medication safety, adherence, and appropriate use. Pharmacists, pharmacy techs, nurses, and doctors can earn 15 accredited CE hours through this program. We continue to expand the program and develop partnerships that broaden its reach. In research, PQA is experiencing a record year. We have 13 projects underway generating evidence on medication access, pharmacist-provided care, patient engagement, medication adherence, and safety. In 2020, we evaluated real-world comprehensive medication reviews to identify key components of the service and describe variation in CMR content and delivery. This foundational work is part of a broader initiative to develop a CMR patient experience survey. We have many studies evaluating pharmacy services. PQA conducted a proof of concept pilot to capture pharmacist-conducted immunization assessment and documentation. We developed a tool for community pharmacists to measure their potential to influence prescriber quality measure performance, and we've demonstrated how medication synchronization is linked with improved adherence scores and better health outcomes. Now, more than ever, research is a critical component of PQA's work to validate services that improve care and outcomes. Since its creation 15 years ago, PQA has been the place where decision makers and influencers come together to advance medication use quality. Through meetings, events, and roundtables, PQA is a neutral convener. Our strength is bringing diverse members together to pursue shared goals and build business across sectors. This has been a banner year for PQA, with more than 20 new members adding to our collective strength. One of the greatest examples of our convening role is the collaborative project that we forged earlier this year with Humana, Pfizer, and Walgreens to evaluate the impact of pharmacist-provided care in patients with diabetes. Our meetings this year have been timely and informative, but I think we all would agree that one of the things we're missing is the in-person networking. Make no mistake, the PQA team has been hard at work to develop innovative approaches to online networking that we can leverage now and into 2021. As part of that effort, we will try something new and different in the last hour of today's summit, a virtual networking reception from 3:30 to 4:30. You don't want to miss it. I always look forward to seeing what our team has dreamed up. Before we move into the virtual reception, I wanted to share a few personal reflections. As many of you know, this Leadership Summit marks my final 2 months of an unbelievable journey leading, building, and growing PQA over these past 15 years. In the earliest days, PQA was launched at an open door forum at HHS headquarters and Dr. Mark McClellan announced his vision for PQA as a consensus-based, fully transparent, multi-stakeholder measure development organization. Say that 10 times fast. At the time, no one knew how PQA would be built, funded, or sustained. Our earliest members took a tremendous leap of faith. They joined, they volunteered, and they gave countless hours to figuring out the right path forward. And when we stumbled on a step or two, we dialed it back and tried again. It took a great deal of grit and determination to build PQA. But I knew then, as I do now, I was never building it alone. There were so many leaders that rolled up their sleeves to make PQA into what it is today. Those same individuals had confidence and faith in me, and that helped PQA in the earliest days when PQA was housed inside of the Cranston home. And I wondered if and when we would ever be able to outgrow the cave, which was how we affectionately referred to the basement of our home. I want to give a special shout out to 5 individuals that are serving on the board or as board liaisons that were with us since the very first day when PQA launched. From CMS on the PQA board, Dr. Jeff Kelman, the Chief Medical Officer who oversees the Medicare Part D program. Michelle Ketchum, the Director of the Division of Clinical and Operational Performance for Part D. And Vicki Ahern, a 14-year CMS veteran who is now the Senior Vice President and Plan President with Magellan RX Management. The other 2 individuals that I want to recognize are Ann Burns and David Medvedev, both on the executive committee. Ann and David are individuals whose passion is unequaled, whose commitment to the profession is unwavering, and whose friendship and leadership have meant more to me over the years than they will probably ever realize. And finally, I need to give a special shout out to my husband Rob and our 2 sons, Chris and Ryan. When PQA was located in the cave and we were preparing for a meeting, it was all hands on deck, creating binders, stuffing envelopes, sorting materials on the ping pong table in the cave. They were always a part of it. PQA was and is as much a part of my family, and they felt a tremendous sense of pride in the organization as it grew. Rob enjoyed leading fun runs at our conferences and building relationships with the PQA runners. Ryan did a membership internship when COVID hit, and you would be surprised at how he could connect the names of our members with the individuals I speak so fondly of. Chris also worked for PQA for a brief internship and joined us last year at our annual meeting and had a great time. I want to thank them for the role they play in PQA's growth. So some of you have asked, what's next in store for me? And I will just have to say for now, stay tuned. I'm not retiring and I am not leaving healthcare. And yes, my husband was glad to hear both. As with PQA, I am looking forward to being part of building something special that addresses a gap in our healthcare system and delivers value for the patients and consumers that we all ultimately serve. For now, I want to recognize and thank the incredible PQA team for their commitment, passion, dedication, expertise, and drive. For the PQA organization, 2020 was the strongest year we have ever had. It was really an all-out team effort on the part of our 22-member team. I also want to thank the board, and in particular, our chair, Jamie Chan, who serves as VP of Clinical Quality for Blue Shield of California. Her leadership and the commitment of the entire PQA board during this pandemic has been incredible. A word about what is next for PQA. I have every confidence that the search committee, which is ably led by co-chairs David Medvedev and Mike Ditto, will be naming the successor to the role of CEO in the near future. And I am planning on a brief transition period once the new CEO has come on board. I am as excited as you are to learn who that will be, and I am trusting the process, as it has been a thorough search, and the committee has done its due diligence throughout this process. I, like you, are looking forward to the announcement. In closing, the state of the Pharmacy Quality Alliance is stronger than ever, and that's thanks to you, our members, our board, and our team. I look forward to keeping the professional relationships that I've come to enjoy with all of you, and will be in touch as we work on the healthcare challenges of today and tomorrow together. Thank you so much for all of you, for the speakers, for the presenters, for the sponsors, and for our team that has made today's Leadership Summit really, truly a terrific and informative day. I know that we can use a lot of the insights that we've gained through the polling as we continue the work of PQA into 2021. But now I'd like to turn over the program to our chair of the PQA Board of Directors, Jamie Chan. Jamie serves as the VP of Clinical Quality for Blue Shield of California. And I have to say, when we both started off this year in January, I would have never expected the year that lay ahead for both of us. Between the pandemic and the transition and all of the extra board meetings, I want to express my sincere thanks for your continued commitment to PQA. So I'll turn it over to you.
Thank you so much, Laura. It has been a great leadership summit. Social determinants of health are critically important for all of us who care for patients and strive to improve the care experience and health outcomes for them. I really appreciate PQA's commitment to addressing these issues and their impact on medication access, adherence, safety, and quality. I look forward to seeing how the PQA team takes today's conversations and the survey results to advance the work. As you had mentioned in your State of the Alliance, it has been a great year for PQA during a really difficult time for all of us. The COVID pandemic has disrupted how we all do business. PQA's continued success is really a testament to our dedicated members, our talented staff, and the importance of medication use quality in our care system. On a real personal note, it has been an honor to serve as the PQA board chair this year. And Laura, I want to thank you for your 15 years of service. You have led PQA from a fledgling startup in the cave to the impactful organization it is today. And as a board member and now as board chair, you have been such a tremendous, energetic, helpful, enlightening partner. And you have really made my job as board chair so easy. And I just am so thankful for you and for that.
Thank you.
I want you to know, and I hope you know, that I'm just one of so many individuals who are grateful for the work that you have done to build PQA to the organization that it is today. And we can't be together today in person, but many members and people wanted to share their thanks for the work that you have done, Laura. And because of that, they've recorded messages that we want to share with you now.
Thank you.
Good afternoon. I'm Jackie Green, and I'm the Chief Operating Officer here at PQA. Last week, someone asked me to describe the heart and soul of PQA, and the answer was easy. Laura Cranston truly is the heart and soul of PQA. And it's amazing that we're 15 years old, but not really, when you think and know who Laura Cranston is. I have had the good fortune of working with her for more than 12 years and was employee number 2. She is brilliant, and her dedication to PQA and its mission is as strong today as it was back in 2006 when PQA began. Membership defines who PQA is, and Laura cherishes our members. She is always looking for ways to connect members to grow their business. Her ear is always to the ground for ways to increase the return on investment that organizations receive as members of PQA. When we were based in Laura's basement, the cave, every time a new member joined, I would stop by the store and pick up a bunch of tulips to celebrate the great news. I would place them on the kitchen table, which, by the way, was the conference room. PQA is 250 members strong today. Laura has laid the foundation, and PQA is poised to address the challenges that face the healthcare community today. We will miss her, but we will know that she will be our #1 champion and look for every opportunity to spread the good word on PQA.
Hello. It's my pleasure to be here to pay tribute to my friend and co-conspirator, Laura Cranston. As a former PQA board member and current chair of the Pharmacy Quality Solutions Board, I have had the privilege of working closely with her over many years. In those years, I've learned a few things. Throughout her career, Laura's causes have never been about herself. Rather, she's a builder, convener, and connector who remembers her roots. And although not visible to most, she is a wonderful yet young matriarch in her family and community. After training at St. John's, her beloved alma mater, like my hat, she found her calling for causes larger than herself early in her career as a resident with ASCP. Then to a decade at NACDS and a focus on a Medicare drug benefit. Larry Kokot, a longtime colleague of Laura's at NACDS, then senior advisor to CMS Administrator Mark McClellan, had a crazy idea that led to McClellan's push for the formation of the Pharmacy Quality Alliance with Laura at the helm. She navigated uncertain financial times for her fledgling nonprofit in a makeshift office, yet kept PQA focused and growing on the right collaborative path. She was effective in attracting the right staff, volunteers, and constituencies to the table, and kept the focus on pharmacy quality measurement for the benefit of patients, not only in those formative years, but throughout her tenure. I've enjoyed being managed by Laura. As a former PQA board member and in service now on the PQS board since that company's spinoff from PQA to establish Equip. Now, as chair of PQS, she and I have developed an even stronger tie. She'll be sorely missed. My experience in working closely with Laura showed me an amazing work ethic. Even more, she showed me excellence in managing nuanced and complex issues with boards and multiple organizations, often with competing interests and always with aplomb. Laura asks the most insightful questions, always with purpose and forethought. She is a master at working a room or a Zoom. In her next life, she could teach board management. Today, I'm pleased to participate in this tribute as we honor Laura and her children, PQA and PQS. Gatherings like this are important symbolically to honor not only our leaders, both staff and elected, but also to encourage future leaders to pick up the cause and to lead with similar excellence and vigor. Laura, on behalf of your profession, your many grateful peeps, and the millions who benefit from the product of your work, thank you.
Let me join everyone in thanking Laura for her service to the Pharmacy Quality Alliance and wish her the very best in her next adventure. And knowing her, it will be an adventure, and I count on her involving me somehow. I vividly remember when I first met Laura. It was over 20 years ago. She was working at NACDS, and I was the executive director of the Virginia Pharmacists Association at that time. We were both in attendance to support an APHA mid-year regional meeting being held in Richmond, Virginia. It was Halloween weekend, and we were both very, very pregnant. And I, unlike her, as always, very professional attire, was in a pumpkin costume. Somehow, even with that, we hit it off and continue today to be great colleagues and friends. When she was serving as the executive director of the Institute for the Advancement of Community Pharmacy, she began her journey that I believe continued throughout the rest of her career and probably will continue, it will continue in whatever pathway takes her next. And that is the very, very unique skill to take a concept, a vision, and turn it into a strong and effective organization, fulfilling a mission that she cares passionately about. And everything that's been done with the Pharmacy Quality Alliance is an epitome of that. Now, just a word about the early years of PQA. I think she and I both have a little bit of battle scars from the early years. I was fortunate to be on the board from day one, and somehow I became treasurer during those early, lean, very, very lean years, only due to her hard work, discipline, and sheer determination has PQA turned into the organization of excellence that it is today. Laura, thank you for your service to the profession, your steadfast commitment to quality and excellence in organizations. I wish you the best wherever your passion takes you next, and I'm sure that our paths will cross.
Hi, Laura. This is Hall of Famer Mariano Rivera. Laura, I wanted to say thank you for everything you did for Pharmacy Quality Alliance. You've been amazing, a great leader, a great closer. After 15 years, to be there and do a great job, thank you, because PQA is in a great place thanks to your leadership, and thank you for being a great Yankee fan. Again, Laura, congratulations and great job. Well done. Bye-bye, babe.
Hi, Mom. It's your son, Chris. Over these past 20 years that you've been a part of PQA, I've really enjoyed getting to see how this company has grown, especially in all the work you've done. We're also proud of you, especially me, seeing all the annual meetings, all the work behind the scenes, everything that's been going on. So proud of you and look forward to seeing what you can do in the future. Love you, Mom.
Hey, Mom, it's your other son, Ryan. Obviously, we were there when you started PQA out of the basement of 9687 South Run Oaks Drive, and obviously have grown it significantly since then. And I know the highlight was obviously having your eldest son work there for 3 months, and I'm sure that made your last year a memorable one. But we've enjoyed watching you grow the company, grow yourself through the company, and have really watched the fruit of your hard work in that. So thanks for being an example of what that's looked like for us.
Hey, Laura, it's your hubby. I just got to say that I'm incredibly proud of you. You really started something from nothing, and I'll just remind my sons, it was actually started out of my office on the 3rd floor of 9687, and I was pushed into the basement, and suddenly PQA grew from 1 employee to suddenly 4 people showing up in our house, and then I got pushed out of the basement back to my old office. So it was really an amazing ride. You know, we have 5 people working out of the home, and conference calls and craziness. I will say I was one of the employees that didn't get a paycheck, so I think I worked on things like Laura's email, Laura's printer, Laura's websites. IT guy, something will never change. But what I'm most proud of is the example that you demonstrated to our boys, and specifically that there's no task that is beneath them. Probably my most memorable times is hanging out at the ping pong table, assembling board books, and making sure that they got put together properly in a certain way. And I think your family and your young men are going to be better for the example that you have set for them. And extremely proud of what you have grown PQA to be, and the impact that you are making in the industry. With your advocating for quality in the pharmaceutical industry. We love you. and congratulations. And I think we're all excited to hear what you're going to be doing next.
We love you,
Hopefully
Mom.
not nagging us around the house. So you got to find something quick.
There you go.
Yes.
Congrats, Mom.
Thanks for the example, Mom.
Hi, I'm Larry Kokot. It's a pleasure to be with you to celebrate the success of the Pharmacy Quality Alliance in another great year. It's truly an honor to join such a distinguished group of leaders, along with the Cranston family, in paying tribute to my dear friend Laura Cranston. I first met Laura when we worked together at NECDS well over 2 decades ago. It didn't take me very long to realize that Laura is a very quick study, a strong leader, and a passionate advocate for her profession. When we launched the Institute for the Advancement of Community Pharmacy, only one person came to mind to lead it. Laura spent the next 6 years as Executive Director of ICP, but little did she know that that was only a beginning. In 2004, I joined Dr. Mark McClellan and the senior leadership team at CMS to implement the Medicare drug benefit. During the course of the deliberation on medication therapy management, Mark and I became very convinced of the need for an organization, an outside organization, to help measure and quantify the value of pharmacist and medication interventions. We agreed that this alliance must be supported by, but not controlled or run by the government. Launching the PQA was no small undertaking, but the biggest challenge was to find a leader to help us get it off the ground. Once again, I could think of only one person who could accomplish the very difficult task of establishing not only an organization, but a movement to convene community pharmacy to come together to promote pharmacy quality and value. To make a long story short, I called Laura and asked her to consider the assignment. It seems like yesterday when I escorted Laura into the press event at HHS to announce the PQA. On the way into the crowded conference room, and much like IACP, Laura turned to me with that, "What the hell are you getting me into?" look, and I remember telling her, "Trust me, Laura, you'll see, this will be a lot of fun." Now, I'm not sure why Laura continues to trust me, but there's no doubt about her vision and her abilities. Mark and I may have christened the PQA ship, but Laura truly jumped into the choppy water, built the boat, and then proceeded to charter a course to 15 years of growth, accomplishment, and success for this organization. Laura Cranston has been an incredible friend and a great partner. She's been a visionary, a builder, at times a tough taskmaster, and a hard-driving leader, but she's also, as you just saw or just heard, a great mother, a great wife, and even a great Yankees fan, which pains me deeply being from the Red Sox Nation. Most importantly, Laura, you are a wonderful, compassionate human being, and you really do set an example for all of us. You deserve the very best of all that is next for you. Hopefully, we'll all get a chance to raise our glasses to you at an in-person venue very, very soon. But in the interim, for now, let me say to you, cheers and congratulations, my friend, on a job well done.
I'm so pleased to have the opportunity to thank Laura Cranston for her career commitment to the profession of pharmacy and to the nation. It's hard to believe it's been 15 years of the Pharmacy Quality Alliance. I remember those early days working with Laura and Larry Kokot and our team from CMS and a core group from the private sector dedicated to coming up with a public-private approach to delivering high-quality drug benefits. This was critical to the launch success of Medicare Part D, which, as you all may remember from back then, was by no means a guaranteed thing. We knew that pharmacists mattered fundamentally for high-quality, patient-centered care involving drugs, and we knew that we had to get some ways to demonstrate how pharmacists could make a difference. So we worked on pharmacy performance measures that would provide that kind of opportunity and enable Part D to recognize and support the most effective use of medications. But the nice thing in working with Laura in all of this was that it wasn't just about solving that problem then and there. It was really about the vision. She created PQA as a center of applied research to inform quality measurement, but to go beyond that, to explore novel ways of solving problems in the delivery of pharmacy benefits and pharmacy services, to close gaps in medication use and quality, recognizing that pharmaceuticals are just an increasingly important part of innovative healthcare that keeps people well. Laura put it all together. PQA began with just a little bit of startup funding and a lot of heart and a lot of commitment from people who are willing to work hard together. And under her leadership, it's just grown from there. PQA today is all over Part D, 15 measures used in the Part D program, as well as other parts of critical CMS programs, including the health insurance marketplace quality rating systems, the Medicaid quality systems, and so many other uses that extend really throughout the whole healthcare system. And the resources that PQA has developed are now being used to improve have been used to improve other areas of care as well. Critical issues that have come up, like opioid prescribing appropriately and safely. And with her leadership, PQA has become a key part of not only improving quality in pharmaceutical and pharmacy care measurement, but also improving and helping the profession fulfill its potential in delivering high quality care. I wish I was there at the 2020 Leadership Summit annual meeting. I understand about 700 attendees are expected virtually. I remember the first meetings of PQA in one small room with just this core set of people who are committed to seeing a different vision for the future in conjunction with the implementation of Part D and really a fundamental transformation of our healthcare system and the use of pharmacy services along with it. It's great to see how far things have come. And looking ahead, we're going to need PQA more than ever as we get to issues related to interoperability and care coordination around truly value-based, person-centered care, initiatives that can bring in addressing social determinants of health. Pharmacists on the front line are really well qualified to help meet people where they are on using medications effectively and helping to overcome any barrier to getting there. And also PQA's role in measuring and supporting current challenges like developing and making available COVID vaccines to help us move beyond the current pandemic. Whatever it is, PQA is going to be a key part of the future. And I know we can count on PQA to fulfill these critical roles as a result of Laura's leadership. So Laura, thanks for all you've done for the profession of pharmacy and for the work that you and all of your pharmacist colleagues are undertaking and will be able to undertake in the future on behalf of the health of Americans.
Thank you so much for that beautiful video montage. That was really, really amazing. And I want to just say thank you for entrusting the leadership of PQA to me since its inception. It's been quite the journey. And Mark, I appreciate your remarks today. I remember sitting in the Gillette Stadium of the New England Patriots, and you first mentioned your vision for starting PQA at a CE program in Massachusetts shortly after the Medicare Part D program was implemented. And I had no idea then that I would be the one to lead this organization. But for me, it's always been about family, friendships, and relationships. And the relationships forged through PQA have been amazing, and they've been long-standing, and they will definitely continue. I want to thank each and every one of you watching today and all of our 250 members, because you are PQA. You volunteer, you give your time, you give your talents, and I also want to recognize my family, because you put up with PQA during the toughest 6 years, and we're always there to help, and it's really nice to have shared this experience with you. So I want to turn it over to Lauren Kirk, and I want to say thank you to Lauren. Lauren has done an amazing job as member engagement, and the only thing he doesn't do is bring tulips now to celebrate every new member that we have. But I want to thank you for today, and thank you for the role that you play within PQA.
Absolutely. I'm glad you mentioned tulips, Laura. I'm very glad you mentioned tulips, because Jackie, our COO, has a whole set of
oh
tulips
man,
for you.
Unbelievable. Very, very appropriate.
Exactly. And again, tulips
Jackie.
have a special place. We figured 250 tulips were going to be a little too much, but Laura, thank you very much for your service to PQA and really a tremendous 15 years.
And I am looking forward to the future of PQA.
Absolutely, absolutely. So as I mentioned before, engagement is a hallmark to PQA and our meetings. So we've designed 4 fun reception rooms after our meeting today. So stay with us for the next hour and learn how to make a seasonal cocktail that Verdi made for us here. You're going to test your trivia knowledge, and you're going to participate in some quick chair yoga, as well as share some thoughts with the PQA staff members. After we finish these final remarks, click on the reception in the blue left bar, and there you will find the information and the links to the 4 reception rooms. We encourage you to flow freely between the rooms, and new rounds of trivia and yoga and different cocktails will be every 20 minutes or so. Thank you to our our reception room sponsors, PerformRx, Involve Pharmacy Solutions, and Johnson & Johnson. But before you break and join the reception, thank you very much for attending the 2020 PQA Leadership Summit. We want to hear from you about your Leadership Summit experience. And please complete the meeting evaluation, which will be delivered to you via email within the next hour. So for now, this is Lauren Kirk, PQA's Director of Stakeholder Engagement, signing off from the 2020 PQA Leadership Summit.